असेल तर तो त्याचा विषय नाही. असेल तर द्या, नाही तर काही प्रॉब्लेम. हेडफोन सांगितले का तुम्हाला आणायला? कन्सोलचा हा लाईनचा पुढे वेगळंच ठेवतो, कारण त्याची वायर तेवढीच आहे. कुठली प्रोजेक्टरची वायर सगळं ते दिसून जाईल. सेटअप ही तुमची कामाची बरोबर आपण टाकली शुभमचं नाही दिलंय का?
Check this, check this, check this, check this,
आपल्या हॉस्पिटलचं सगळं तुम्हाला माहिती आहे की 6 महिने झालं मी मागे लागतोय सर. याचं सगळं सेटअप ऑडिओला सगळं घेऊन सगळं आपला सेटअप करून घेऊन मिक्सर सगळं इथले खाली ठेवलं बरोबर आहे. खाली ठेवलं
जास्तीच पडला त्याच करते
check test, check test, check test, check test.
हो काय झालं दिसते ना नाही नाही ते लाईव्ह आहे ना त्याच्यामुळे थोडं हां
Good morning, ladies and gentlemen. I am Dr. Riya Bhattacharya, the host for today's event. It's my immense pleasure. Hello. It's my absolute pleasure to welcome you all to Manipal Med Hospitals, to Manipal Med Connect 2025 in association with IMA-PCB. It is an academic initiative by Manipal Hospital Bane in association with IMA-PCB in Manipal. As a Manipal, we believe that knowledge grows when shared. This is exactly what the CME aims and achieves to be. Through this platform, some of our finest experts will share their insights in medical on range of relevance and medical thought-provoking topics, bringing together evidence-based practice and their clinical expertise with latest advancement in healthcare. This is just not an event, but it's a stage to learn, to share, to connect and foster relationship within the medical fraternity through exchanging ideas. And our collective commitment will strengthen our clinical excellence in society. After all, at heart of Manipal lies three core principles, that is clinical excellence, patient centricity and ethical practice. So to start with, I would request Mr.Anand Mote, our cluster director, to address the audience.
I will not take long. What I just want to do is that thank IMA-PCB for giving us the opportunity for association. I'm sure that you will all enjoy this particular sessions quite well. We have selectively chosen various topics and requested some of our some of our clinicians to give their knowledge on various topics. I hope this session you will all enjoy. Welcome you all and at Manipal Med will continue to do this initiatives. Thank you very much.
Thank you, sir. We sincerely thank IMA-PCB for their support in making this event possible. We extend each of you our gratitude to join us today. We look forward for an engaging and insightful session ahead. Let's connect, learn and grow together. To start with our first session, it's very informative session which is based on role of new modalities in interventional cardiologist. To chair this session, I would request Dr. Rajdatta Deore to please come on the stage. Dr. Rajdatta Deore is an experienced interventional cardiologist with overall 22 years of experience in medical field. Dr. Deore expertise includes many coronary interventions with via radial and transfemoral routes, balloon valvuloplasty, structural heart defect, and pacemaker and ASID implantation. His commitment to patient-centered care and advanced cardiovascular treatment makes him trusted name in that field of cardiology. I would like to request Dr. Abhishek Karmalkar to be on the stage. He is an expert general physician and diabetologist with overall 15 plus years of experience. He has completed his MD in medicine followed by IDCCM, which enhances his ability to manage complex medical conditions. He provides expert patient care at present at Sterling Multi-Speciality Hospital, Pune. His expertise in diabetes and thyroid management has positively impacted numerous lives. Also, his focus on evidence-based medicine and compassionate care makes him trusted name in medicine fraternity. Welcome, sir. I would request Dr. Deore to introduce our speaker.
Good morning, everyone. I would like to invite Dr. Abhijit Joshi. He is Senior Interventional Cardiologist, HOD, at Cardiology Department, Manipal Med Hospital. He has completed his fellowship from European Society of Cardiology. He is elected as President of Cardiological Society of India, Pune branch. His area of expertise are complex angioplasty, pacemaker, CRT, balloon valvotomy procedures, ICD, heart failure management, and chronic total occlusion. Over to Dr. Joshi, sir.
Hello.
Thank you, Dr. Deore, for the kind introduction, and thank you, PCB, for allowing us to have a wonderful meeting on special topics which are for our day-to-day interest. Today I am going to speak on some of the new modalities in interventional cardiology, especially focusing on the imaging and cardiac physiology or coronary physiology. Can we have the lights off, please? Yeah, that also. Yes. Pointer? Okay. So our blocks are something like this, and which way we look at it gives a different impression. If we look from this side, it looks like a very tight block, but if you look from here, it will look as a minor block. Look at this now. This is a 40-year-old gentleman presented with chest pain, uneasiness, some block in the right coronary artery. What to do now? Whether I should intervene, whether I should put him on just medicines and follow, whether I should do further tests. So, only coronary angiography has its own limitation because of its just a two-dimensional aspect. So, there are newer modalities which help in assessing the need for intervention, assessing its significance and assessing its configuration. To understand that, we do fractional flow reserve, that is a physiological testing which decides whether the block is significant or not, and sometimes if we find that the block is significant, to understand what is the block is like, what is the constitution of the block, whether there is a calcification or whether there is fibrous tissue, we need to do intravascular imaging. And nowadays we are facing this problem because our population is aging, and more people are coming at little later age, post bypass population, post angioplasty population, or a PCI done 15 years back, 20 years back, bypass done in 2005, 2010. All these patients are now coming back with angina, chest pain, acute coronary syndrome, and here is the role of coronary imaging, which helps us in understanding the blockages, understanding the pathophysiology, and planning the procedure. Two clinical settings, whether the in particular patient the angioplasty is indicated or not, and if it is indicated, what are the technical aspects, characterization of the lesion, and how to get the best possible result out of the angioplasty. So fractional flow reserve is the way we can judge the significance of that block. If you can imagine a block in the proximal LAD, which is 80 to 90%, it appears very tight. Sometimes when you do the physiology, the block may not be that tight, and if the FFR is negative, then we don't have to intervene. As against a very non-critical appearing lesion in the left main artery, which may not be seen very tight on the left main coronary angiogram, could be a very tight lesion on the imaging or in the physiology. So what is the principle? It is the ratio of the flow flow beyond the lesion and the flow before the lesion, proximal and distal, and we calculate the PD by PA, that is the hyperemia index of distal flow versus proximal flow. And if the index, that is in a normal artery, the index is normal, that is PD by PA is 1, that means the artery is clean, there is no obstruction, the physiological flow is good. But if the FFR is 0.6, that means only 60% of the blood is flowing, and there is a very high chance of development of MI in such patients. And after the angioplasty, the FFR improves to 0.9 or 0.95, that means your angioplasty is really successful. So how it is done? So there is one machine and a catheter which has a catheter and a wire. It is called pressure wire. It has a sensor on that tip of the wire. We pass, first thing is we put the catheter inside the coronary artery, pass that wire beyond the lesion, about 3 to 4 millimeter beyond the lesion, and after balancing and after getting the zeroing properly, we check the difference between the proximal and distal pressures and flow. Then we induce the hyperemia. Hyperemia means we give adenosine injection or nicorandil injection to get the maximal hyperemia and see the difference. We want to increase the difference between the PD and PA. And that helps in understanding the physiology of the lesion. So normally it is 1, and FFR is not influenced by the arrhythmias, the high heart rate, low heart rate or contractility. It is physically relates to the influence of epicardial stenosis to the myocardial perfusion area. If it's a big area which is being supplied by that coronary artery, the chances of the blockage, chances of the physiologically being positive is more. As you can see, consider that there is a proximal block of 80-90% versus a very distal block of 90%. So distal block being 90% may not be physiological significant because it is not subserving the big myocardia. So we may not have to intervene in such cases, whereas a 60 to 70% appearing lesion in a proximal artery can be supplying the more area and can be dangerous. So that can be physiologically positive. So this is the console, this is the pressure wire. This is the small carton of that FFR. Look at this. This is a normal artery, and now PD by PA is 100 by 100 is 1. But if there is a block here, after passing the wire, if it senses that the distal flow is less as compared to the proximal flow, it is 70 by 100, that is 0.7. So this is a physiologically significant lesion. So what is the cutoff? 0.75 to 0.7 is the cutoff depending on which machinery you use, which hyperemia you induce. So after inducing the hyperemia, if the FFR is more than 0.75 to 0.8, that means whatever it appears on angiogram, that lesion is not significant and you can safely leave this lesion for medical management. As against, if after hyperemia the ratio is 0.75 or less, or sometimes in some machines 0.8 or less, even though the lesion is not appearing very significant on coronary angiogram, it is subserving the huge motion of myocardium, and this is the ischemic myocardium, and there is definitely a point in intervening such lesions. Look at this lesion now. This is a proximal LED lesion appearing maybe critical. Dr. Deore will agree with me. One may tend to put a stent on this lesion. But when FFR was done, it is 0.93, and the CT angiography follow-up after 1 year on medical management, the plaque was regressed after rosuvastatin and aspirin. So these are the very important techniques in preventing or avoiding unnecessary intervention, because angioplasty is not just putting a stent, but you are giving another disease to the patient. It is a metal. There was a big trial called a Deore trial, where they have studied the patients in whom the FFR was more than 0.75. What they found, that if you perform angioplasty in FFR more than 0.75 patients, you are likely to do more harm than those patients managed medically. So there is a definite evidence, scientific evidence, that FFR helps in understanding the physiology, helps in understanding the lesion, whether such lesions to be addressed or not. It's a FAME trial, 2-year survival free, MACE free interval. If you look at it, if FFR guided, it's found to be much superior. There are less incidences as compared to angio guided. 28% lower incidences of major adverse cardiovascular events. So it is proved scientifically also. Many times we come across multi-vessel disease, triple vessel disease, and patient is maybe referred to bypass surgery. But if you really do the FFR in such patients, only 35% to 40% of the patients have real triple vessel disease, and most of the lesions may be physiologically non-significant. Say LAD shows physiological significance, FFR of 0.65, 0.7. Circumflex, FFR is 0.8, RCA 0.85. You just leave these RCA and circumflex and for medical management and just do the angioplasty of LAD. These patients behave as good as complete revascularization in such patients. So physiology helps in guiding whether these patients really have triple vessel disease or not. As against, if some patients have non-critical looking lesions, and if you do FFR, intervening in such patients is very important, and that saves their life. So both ways. Many times we have problem with the assessing the left main coronary artery disease, and depending on how much the blockages are, how tight the blockages are on imaging, sometimes we have to do FFR, and if FFR is negative in such patients, even though the areas are less, we can safely leave these lesions and keep it on medical management, whereas if FFR is positive, it is better to intervene either CABG or angioplasty. Let's go to imaging, how imaging has added in our practice. So angiogram is a gold standard for imaging, but it provides only two-dimensional information similar to the road map. But the angiographic lesions, as we saw in the first slide, they are many times eccentric, or they may not be seen properly on proper angiogram. So what are the ways? So intravascular ultrasound, which is a proved modality being practiced since last almost 18 to 20 years all across the world, helps in understanding the inside of the artery. You can see this. This is a catheter, which is IOS catheter inside the coronary artery. You can see the intima, you can see the media, external elastic lamina. The artery is very nicely visualized. What is the use of this intravascular ultrasound? Besides the strategy and sizing, if there is a block, what size of stent I am going to use, what strategy I am going to use, if the block is of calcific nature, hard in lesion, or whether it is a fibrous lesion, whether there is a big side branch coming out of it, what is the length of lesion, and what is the plaque composition. All this information you get before starting the procedure. After ballooning, after the plaque modification, you can also understand whether any further modification like rotablation or intravascular lithotripsy, which helps in cutting the calcium, is required. And after putting the stent, how the stent is working, whether the stent is properly apposed or not, is there any complication of stenting like dissection, proximal or distal edge dissection, or there is any thrombus, there is a plaque shift in the side branch. All this information we can get through the intravascular ultrasound. And these imagings are nowadays considered as class 1A indication in patients who have left main coronary artery disease, and if we are intervening the left main coronary arteries. Look at this angiogram. It is looking inconspicuous. This left main disease does not look very tight on the naked eye on the coronary angiogram. But when intravascular ultrasound was done, it turned out to be very, very difficult to manage the lesion. Very high fibrous plus calcific nodules in between. So it's a very tight lesion, and left main disease If there is a tight, it means it is subserving a huge portion of the myocardium, almost 80% of the myocardium is subserved by this particular artery. There are different characterizations. The fibrous plaque looks like this. If there is a rupture in the plaque, you can see there is an ulcer. If there is a thrombus, you can see the thrombus inside the blood vessel. Or a calcification, it looks like a hard lesion with the black scatter behind it. So, in multiple studies, it was found that intravascular ultrasound guided angioplasty was much superior than only angiography guided angioplasty in reducing the major adverse cardiovascular events. So there is significant difference. If IVUS guided angioplasties, the survival was 95% at the end of 2.5 to 3 years, as against without IVUS, the survival was 85%. So there is a significant gap between the two results. So that proves the point that if we do image guided angioplasty in difficult lesions, it gives a long term better results. Look at this patient, 65, 70-year-old patient with unstable angina, bad calcific lesion, lesion in the ostial LAD, proximal LAD, ostial ulcer and left main bifurcation. And intravascular ultrasound show very tight circumflex ostial lesion, very tight lesion from the full back in circumflex and LAD. And this was the result after angioplasty. And the areas also have improved. The circumflex 6.2, distal left main 14, ostial LAD 8.5. So all these areas have improved. So you can actually visualize how the stent has worked in this patient, and that culminates into the reduction in major adverse cardiovascular events over the period. Because the areas achieved are important during angioplasty, that tells us whether patient is going to have wrist stenosis or not. Again, one of the important risks is drug-eluting stent failure, that means wrist stenosis. So we see now a lot of patients who come with post-angioplasty angina, say after 2 years, 3 years, 5 years down the line, and we need to understand why the stent has failed, whether the stent was not properly apposed, the stent selection, size selection was inappropriate, it was a 3.5 millimeter vessel and you just put a 3 millimeter vessel, 3 millimeter stent, not went up to 3.5 or 4. Such patients can come back. Or acute presentation, patient with acute coronary syndrome, we put the stent and third or fourth day we find that the patient is thrombosed. So why there is a thrombosis? So is there any mechanical problem? And mechanical problem could be malapposition, edge dissection. So all these things can be visualized on intravascular ultrasound.
My patient is a 59-year-old hypertensive and long-standing uncontrolled diabetic patient. He suffered
Is it audible? So this patient was very notorious. He came to Niramay hospital that time when I was there practicing, and he came in a cardiogenic shock. 1 month back he saw me in my OPD and I told him you should undergo all these tests, and he himself, being a LIC agent, insurance company agent, he wanted to postpone it, and then he landed up with acute cardiogenic shock, LAD, and our LAD was stented that time on emergency basis, and OM was also stented. Later on he developed chest pain again after 2 years, and that time we have seen that there is a instant wrist stenosis in the LAD as well as OM. So there was a re-blockages of the stent. Again, February 2022 came with effort angina, positive stress test. When we evaluated, we find that the lesions have progressed. So RC lesion which was not there has progressed. The left coronary artery ostium, LAD ostium has worsened, the OM has re-stenosed. Now what to do? Then the standard practice in re-stenotic lesion, we offer them bypass surgery because it's a stent failure in such patients. But the patient was absolutely adamant, no, I don't want to go for bypass surgery. So here comes the role of intravascular imaging. So first we did the right coronary procedure, which was straightforward. Simple straightforward right coronary angioplasty. with a good result. Then here we did the FFR. So we did the physiological testing of the mid LED lesion and ostial LED lesion, which turned out to be positive. Both were. It is RFR, not the FFR. So before hyperemia, we can assess the cutoffs are 85 and here, and both are significant lesions. So LED lesion as well as the mid LED and proximal LED lesions both were heavily calcific. The mid was fibrotic and proximal was calcific, but what we found that the left main artery was stable, so we could manage without crossing over into the left main, and the LED was stented, and these were the final results. So then OM was also stented similarly. With good areas. So the point here was that when there is a drug-eluting stent failure, restenosis, you have to image these patients, find out why it had happened, and now the next case will tell us why it had happened. This is a 68-year-old gentleman. He had acute coronary syndrome and he had anterior wall non-ST elevation MI. So he went to a peripheral hospital, and where on emergency basis the proximal LED was stented, and there was a proximal left main stenting also was done. So left main plus LED was stented that time. He was doing well, and then a month back he presented in Manipal hospital with crescendo angina, troponin positive. He was hospitalized into the ICU, and then when we did the angiogram, what we found that the left main restenosed, the proximal LED restenosed, and we wanted to find out why it had happened. And here we found that the stent was not at the ostium of the LED, but it was in the proximal to mid LED. There was a very tight disease beyond the stent, and a tight restenosis of the even left main also. So we did the imaging of the LED and left main coronary artery, which showed there is 360-degree calcification, and to our surprise, the stents were underexpanded. This was a real-time pullback, intravascular ultrasound pullback. This is, you can see this white thing is heavy calcification, and when we pulled it back right up to the left main, even the ostial disease, the ostial LED had very small areas. The left main also, distal left main also had a very small areas. Left main should be more than 8 and 9, LED should be more than 6. So these areas were grossly decreased. And what we found that the LED stent was underexpanded because there was a lot of calcium behind it. You can see this calcium. This is a stent boost image on the cath lab. Even the distal LED, mid to distal LED has a lot of calcium. These black lines are calcium, tram track appearance. So only ballooning or cutting balloon would not have helped here. So we had to use the lithotripsy, which our urologists use for breaking the stones. So it's a lithotripsy, balloon-based lithotripsy, where intravascular lithotripsy, where we pass a balloon and there are emitters on the balloon which emits the sound waves and breaks the calcium. After giving 60 pulses proximally and 20 pulses distally, the calcium broke, and then we could expand the stents properly. You can see the nicely patterned and large vessels being seen. If you remember the previous image, now the stent is nicely expanded, and which was confirmed on the intravascular ultrasound that the areas ostial LED 8, distal 7.4, distal left main 8.2, proximal LMC 10.5. These are the areas which we achieved, and these are the areas which determine the long-term restenosis in such patients. So this was the final result we could achieve. Then right coronary. Similarly, right coronary had also restenosis, which was treated in the same manner. So severely calcific lesion requires a lot of aggressive plaque modification using cutting balloon, sometimes rotablation, or sometimes intravascular lithotripsy. These are the new babies in interventional cardiology to modify the plaques, and it has to be done under image guidance to understand whether to see the adequacy of procedure and to see whether the stent is expanded properly or not. In last decade or so, optical coherence tomography, which is generally used by our ophthalmologist colleagues in their practice, is being used in interventional cardiology for imaging of the arteries. And it has the beautiful high intensity, high density HD images. You can see the same thing which is seen in the intravascular ultrasound, which is very nicely visualized. So this is the inside of the artery intima, the fibrous plaque, the internal elastic lamina, the media, and the external elastic lamina, which is everything is very nicely and clearly seen. Here principally it uses the near infrared light, which helps in characterization of the plaque. So this is how it is done. A small catheter is crossed, passed beyond the lesion, kept it beyond the lesion, and we have to give the contrast or saline injection to take the blood out of the circulation for a few seconds and get the best images. The beauty of OCT is it is a fast pullback, very high density, high quality images, and it understands the pathology of plaque in very nice and very crystal clear manner. So this is a fibrous plaque which is homogeneous. This is the internal elastic lamina. This is all plaque which is protruding inside the lumen, external elastic lamina, adventitia. Everything is seen very nicely. A calcification which is seen as a bright spicules on the intravascular ultrasound appears as a very sharp black scatter, and you cannot see the depth of the calcium. So how deep is the calcium we don't understand, whereas it is very well visualized. So one of the indicator of intravascular lithotripsy or rotablation is how deep is the calcium. If the calcium is really deep, you have to go very aggressively on plaque modification. So this is how the images are: thrombus, plaque rupture, thin cap, fibroatheromas. All these things are very nicely visualized. Some patients, when they come with restenosis or apposition, here the stent malapposition, you can see the hanging stent studs. So these are all things which we can easily see on the imaging, coronary imaging. This is a thrombosis, very dense in neointimal hyperplasia, and a patient coming back with the ACS. Dissections again are very important to visualize, and this is a three-dimensional demonstration of how you can look through the stent. This is how it is seen. You can see here it is a how pullback from distal to proximal, and these are the stent studs, whether it is expanded or not, whether there is a dissection, how is the side branch. So all this information can be achieved with this. Okay, I'll finish with the last case. He's a 53-year-old guy, a friend of mine. 3 days back, he came to my OPD for a routine evaluation. His stress test was normal, but his lipids were high and his HbA1c was 6.5. He lost his father because of MI at the age of 55. 3 days after, he went for a walk on a hill and presented with chest pain, ST elevation, inferior wall MI. Left coronary arteries reasonably good, minor moderate lesion in the LED artery. But the right coronary was very badly diseased. So we ended up in putting stent in the distal, mid and proximal RCA with a good result. This looks like a good result. I can understand, even Dr. Deore also will say the same thing. So it was a good result. Next day patient presented with chest pain. This is what happened, the artery closed. So I got a call at 8 o'clock, Abhijit rushed, his wife called me. So I went there. This is what was totally blocked artery. Now my first thought is, I have not put the stent on the ostium of the RCA, or I must have missed, or I must have caused some dissection. But fortunately at the same time I called up my OCT guy also, and then firstly we ballooned up, thrombus aspiration was done, ballooning was done with 2 millimeter, then 3 millimeter. Then thinking that I might have injured the ostium during angioplasty, I did one more stent of 4 by 18 millimeter in the proximal right coronary artery. But when we did the OCT, what we found that the distal part of the RCA, and this time the patient was having a lot of pain. So he was telling, even though after getting the T3 flow, the pain was continuous. And this is what is a deep, long dissection, 6.5 millimeter long dissection in the distal right coronary artery, which was not even tackled that time. We could not see it on an angiogram. And then ultimately, we put another stent much beyond in the area where we found the dissection. And the moment we deployed the stent, the patient said that the pain is gone now. And we found the T3 flow and the dissection was sealed up. So in this case, if I would not have had that imaging, intracoronary imaging in my hand, I could not have even seen why this has happened. I would have always thought about proximal dissection, incomplete apposition of the stent and all these things. But on the contrary, the stent were very well apposed, there was no proximal injuries, but it was a dissection right at the end of the right coronary artery. So I don't go to the second case, I will just conclude. This is the date. So, European Society of Cardiology 2023 consensus guidelines have shown that there is evidence to support for the new standard of care. That is, the intravascular imaging has really helped in getting the procedure in a better way, reducing the complications on table as well as long term, and having less major adverse cardiovascular events as compared to the angiography guided angioplasty. So, compared to angiography guided PCI, intravascular imaging guided PCI has reduced either with OCT or intravascular ultrasound, reduced the target lesion failure by 32%, 46%, 20%, and 29% reduction in cardiac death, target vessel MI, and target vessel revascularization. And more very important, that stent thrombosis has reduced by more than 50% using intravascular ultrasound. So even there is a trial in acute anterior wall MI. If you do image guided PCI in acute anterior wall MI, you reduce the stent thrombosis rate by almost 50%. So point to remember, these new modalities, these are the new tools which I will choose, a right tool for the right job. None of the tool is single and all in one solution. Intravascular ultrasound, FFR, OCT have complementary role, and all of them are important in the specific situations. Thank you very much.
Thank you, sir, for the very difficult topic made very easy, and very beautiful images which have absolutely clarified all doubts. This was a wonderful lecture. And after listening to this lecture, what I am feeling is that after angiography, almost every patient may get some help by doing such kind of intervention. So,
at present,
where
cost constraint is still there.
That is true, but then if cost is not the concern, then probably
yes. Many of the centers, most of the centers in US and Europe, they do all their angioplasty image guided. That is their standard of care. But their insurances cover them. Our insurances are still not covering them. So that is our issue.
So the trials which have been shown are on the random patients, not specific patients.
Now we have to choose our patients for this imaging. If we are talking about the left main disease or left bifurcation stenosis or long lesion, calcific lesion where we are going to modify the plaque, we are going to use rotablation or intravascular lithotripsy. These are the patients which we at present choose, or multivessel disease.
So basically angiography is just a delineation of anatomical stenosis, and its physiological significance has to be checked, and that we see on FFR. So anatomy versus physiology, it is not the case. It is both anatomy and physiology. Both are equally important in managing the
Complementary to each other. Yeah.
Thank you, sir.
Thank you. Thank you so much.
I would request our chairperson to felicitate Dr. Abhijit Joshi.
Dr. Abhijit Joshi, can I ask a question? Nobody offered a question. Can I ask a question?
Please, sir. Please, sir.
Can FFR be done in renal arteries? Because many times we see cardiologists putting in a stent at 70%, which we thought, which we think that probably was not
Both
required.
FFRs as well as imaging, both can be done.
Is there any study on renal
I'll
arteries?
look into it because nowadays renal angioplasties are not done so frequently. We are doing most of the work radially and we don't go in your territory so
Yes,
frequently.
no, but I think Dr. Ambekar and Dr. Siddesh will agree with that. Still we see.
renal artery stenosis, they are recommend that during angiography we can take a pullback gradient through the catheter also.
Right.
That's kind of crude.
But selectively you have to calibrate the renal artery for doing this, isn't it?
Yeah, because
we generally do it.
because we are in aorta, so that angiographic catheter is usually small bore compared to angioplastic catheter. So pullback gradient, it is recommended that if gradient is 20 millimeter or 20 mm Hg or more, then it is significantly. Then
What
we
do
can
you
say.
Dampening of the pressure is one of the very important tools
Correct.
in understanding the
Yes.
lesion. But yes, of
Thank
course, if you are intervening, see these procedures are recent one, these FFR and we have never utilized it in renal artery stenosis. But very good idea.
One of the problems that we face is if you, what we used to do previously, when you go inside the renal artery, you may miss osteal lesions at that point. So it's better to take a flush angiography also at that time to see whether there is any osteal lesion.
Mostly it is osteoarthritis, so we have to do angiogram.
So where does the stress thallium stand in all this?
These are intervention procedures. Yes, stress thallium has important role. If patient has chest pain, positive stress test, we are not sure whether it is really positive or not. First thing that. Second thing is patient has multivessel disease. You have LAD and RCA, both lesions are moderate. Whether LAD is critical or RCA is more critical, again physiological testing. Your thallium is physiological, non-invasive testing. Like FFR, what we do on table, off table we do thallium.
Also nowadays more people are doing CT angiography, even in asymptomatic patients. So in that case also stress thallium is helpful, so that anatomical stenosis, the as in CT scan, can be verified on stress thallium whether it is physiologically important.
Dobutamine, stress echo and cardiac MRI, both are also physiological tests which can be utilized in our patients.
Second, do we really need to stop doing PMP and start doing
No, stress test and its own.
because many of the, I mean, there's a lot of
Many of the people say that stress test is not of importance. Yes, there is a lot of other important information to the patient, whether how is the blood pressure behave, if there is a drop in blood pressure, how is the, if you interpret the stress test properly, most of the times you can make out a diagnosis. If you look at the inferior leads and ST depression, it makes no sense. You have to look at the lateral leads with down sloping or flat ST depression more than 2 millimeters, which recovers in recovery phase and then reappears in recovery. These are all the parameters which you look at. It can be shown simple, non-invasive and inexpensive test.
उनको देना है अभिजीत सर I'll request Dr. Srirang Ranade to felicitate Dr. Rajdatta Deore. I'll request Dr. Saurabh Kiste to felicitate Dr. Karmalkar. Thank you all. That was very interactive session. So moving forward for more such sessions, our next lecture is based on kidney transplant, expanding the donor pool. So to chair this session, I would like to call upon Dr. Niranjan Ambekar. He is renowned nephrologist in Pune with strong background in nephrocare and education. He served as an associate professor of nephrology at BJ Government Medical College and Sachin General Hospital, Pune. He trains the next generation of specialists while providing exceptional care in nephrology and kidney transplants. Dr. Ambekar has been a secretary of Society of Nephrology West Zone chapter, where he played a key role in promoting advancement in kidney health. His expertise and commitment continue to shape the future of nephrology in region. Next, I would like to call upon Dr. Siddesh Dhaygude, an expert nephrologist in Pune. He is a highly skilled nephrologist with overall 25 years of experience. He specializes in chronic kidney disease, diabetes-related renal problems. He is offering advanced treatment at Dhaygude Clinics and Niramaya Hospital. Dr. Dhaygude is an active member of esteemed medical societies contributing to research and awareness in nephrology. He is dedicated towards preventive kidney care and innovative treatment strategies, which has made him trusted name in renal health care. I would request Dr. N.C. Ambekar to introduce our speaker.
Good morning everybody. I would at the outset thank Manipal Hospitals for inviting me and Dr. Siddesh Dhaygude as chairmen for this session. Dr.Tarun Jeloka, just a few words about him. I don't really need to read this. As HMT was timekeeper to our Indian nation, he is our timekeeper to our nephrology society. So I am extremely cautious and aware when the program has to start, because he otherwise gets really upset. He was the secretary of the Peritoneal Dialysis Society of India, and among the Pune nephrologists, he was the first to have his FRCP, his Fellow of Indian Society of Nephrology, and so many degrees that I have lost count of them. With that, I hand over the mic to him, and 20 minutes lecture and 10 minutes for discussion. Transplants have gone a long way. We started doing life-related transplants in Pune in 1990, cadavers in 1998, I think. And over to you, Dr. Jeloka.
Thank you both the chairpersons. Thanks IMA-PCB and obviously our own management, who has given this opportunity to be with you and interact something about kidney transplants. So this is my view on expanding the donor pool, which I'll talk, as you said, maybe less than 20 minutes, 15 to 20 minutes if you agree. And then I would request both the chairpersons to have their opinion on how to expand the donor pool for a few minutes, and then we can have an interactive session with the audience if there are any comments or questions about it. So let me start with a few questions to think for yourself. Keep it in mind and ponder over it while my talk goes on. So the first question is, what is the prevalence of CKD in India? Is it 5%? 10%, 15%, or 20%? This is my first question. Another question is, what is the best modality of renal replacement therapy? Is it peritoneal dialysis, hemodialysis, or just palliative care, doing no aggressive management just with medicines? And maybe the third question. It's okay. And the third question is, what is the limiting factor for solid organ transplant or kidney transplant in my case? What is the limiting factor? Is it finances of the patients, the availability of donor, approved centers or qualified nephrologists and transplant surgeons in kidney transplant and respectively in their specialty. So these are 3 questions, just think about it and answer in your own mind. So the overview of my talk is a little introduction followed by what are the limiting factors and then how I think we can expand the donor pool for kidney transplant. So this is a last month publication in Nephrology 2025 January, where they have done a systematic review and meta-analysis, the best available evidence on CKD prevalence in India, and you'll be surprised to see that the prevalence has increased from 11.12% in 2011 to 2017 to 16.38% between 18 to 23 in Indians aged 15 years and above. So few years back we used to quote that the incidence of prevalence of CKD is 10%. Now it has gone up to 16.38%. Indian study meta-analysis published in Nephrology journal. So it is not long when we may see that the CKD prevalence has increased to 20%, which means 1 out of 5 people sitting in here may have some degree of chronic kidney disease. Very worrisome. What are the options available for advanced or stage 5 chronic kidney disease? Peritoneal, hemo, transplant, and as I said, palliative care. So who decides? Obviously the patient decides. It is their choice, what do they want. They want to go for palliative care or they want to go for aggressive treatment, any of these. But also it depends upon the underlying medical condition of that particular patient. We cannot generalize the treatment to the entire population of CKD. So some patients, for example, this slide which I had put in as a question, some patients may not be suitable for peritoneal dialysis because of underlying abdominal conditions or multiple abdominal surgeries. Similarly, some patients may not be suitable for home or any hemodialysis because of the access issues or poor cardiac conditions. For that matter, even for kidney transplant, some may have advanced liver conditions, advanced heart condition, advanced brain condition, cancers, etc., etc. So it has to be individualized. I can't give a generalized statement, but by and large, and similarly, some patients may be so morbid that any of these therapy is not suitable, and probably palliative care is the best treatment for that particular patient. But by and large, if you ask me to generalize a statement, then kidney transplant is considered the best treatment as renal replacement therapy. Why? The question is why, obviously you'll ask me. So these are 3 principal reasons why kidney transplant is considered best for all aged patients. Number 1 is better survival. So what I quote is, to my patients, they have double the survival as compared to staying on dialysis. Better quality of life for sure. They live like a normal person. In dialysis, they have to come 3 times in a week for hemodialysis and do peritoneal every day at home. And then cheaper also. So don't take this notion that transplant is a big surgery, they have to invest a lot of funds. They do, but studies are there where they have compared the finances of patients who are on dialysis versus patients who have underwent transplant. And what they have found, at the end of 2 years, the expenses are same, after which there is about 1/3 to half the cost as incurred in dialysis, any of these dialysis. So for these 3 reasons, transplant is considered the best renal replacement therapy. Now coming to the second part of my talk is what is the limiting factor for kidney transplant. So obviously all these are limiting factors. Some patients may have short of finances, there might not be approved centers in suburban areas or rural areas where patient is. There might not be qualified transplant surgeons or nephrologists in many of these. We have seen in Maharashtra nowadays the nephrologists are available in almost all small cities as well, Satara, Sangli, Karad, etc., etc. But at one time, 10 years back, probably we did not have. So these are also. But to me, all these can be managed. Finances can be managed with MJPJY and Ayushman Bharat. They have approval for kidney transplants as well. And there are centers where you can go and get a transplant free of cost. So finances can be managed. Centers you can move from Sangli to Pune or to Mumbai or to Aurangabad or to any of these places. So all these can be managed. But what cannot be managed is donor. How do you manage donor? It has to be a related donor, or how to expand, that is topic of my discussion today. So to me it looks like donor is the limiting factor. Why is that? Number one is willingness. So nowadays people have nuclear families. If you ask your siblings, most of the time what I have seen is they are not ready. They don't, patients are scared even to ask donors, their siblings, whether they will donate a kidney or not. So willingness is important. Fitness. So if you see, most of our patients who require transplant or go into end-stage renal disease are of middle age. And when you ask their parents, the parents may not be medically fit. If you ask their children, they are fit, but probably they may be underage, below 18 years, or the parent or the patient do not want their siblings to donate to them. So fitness is important. There may not be matching. So most commonly what we see worldwide, it's not Indian studies, spousal donation is the most common donation in living donor transplant. So it may not be matching. And the last is blood group compatibility. So blood group is not matching, that creates another problem of doing a simple straightforward transplant. So these are few issues with donors. So how do we have a best donor for one particular given patient? Let's go through few examples. I have 10 minutes. So example one. So this was 49, these are all real cases. I'm specifically quoting cases from my old transplant, so you can see that how they are doing right now after several years. So 49-year-old male diagnosed with biopsy-proven IgA nephropathy, diabetic ESRD, wants kidney transplants, parents have died. There are no siblings who are willing. As I said, children were too young, wife was willing, started the workup, blood group was mismatched, patient was A positive, wife was B positive. What do we do? So what we looked into is we asked them to wait for some time and look for a reverse pair. So another pair came in, 48 male, diabetic ESRD, wants kidney transplant. Same story, here also wife was willing, blood group again was mismatched, patient was B positive, wife was A positive. So what we can do in such circumstances is do a swapping of donors. So one wife donates to the other one and the other wife donates to the first one. So what we call is paired kidney exchange. So that is one way of expanding the donor pool in living donor transplant. Here patient 1 received kidney from donor 2 and patient 2 received kidney from donor 1. So that is one way of expanding the donor pool. So kidney transplant was done, both these pairs, 24th December 2021. They are doing very well. Patient 1, first patient has a creatinine last month of 1.22 and patient 2 is 0.71. He is 100 kg, he is 70 kg. There is some difference in creatinine, but they are doing very well. These are all recent creatinines. So this is one. Moving to example 2. 43-year-old male and stage of unknown cause, wanted kidney transplant. Only willing donor available was mother. She was 62, female, workup started, blood group again mismatch. Patient is A positive, mother is AB positive. Is swap possible? What is your thought? Can we wait for somebody, donor who is AB and can donate, donor is A who can donate this patient, and recipient of the other recipient is AB who can get this donor. Now there is a problem here. AB donor is a problem here. So donor who is AB or recipient who is O is very difficult to have a swap, because if the donor is O, they are universal donors. AB recipients are universal recipients. So if other pair recipient is AB, then he or she can take kidneys from any blood group in their family. They will not wait for swap. So here it is difficult. How do we manage this now? So another way of expanding the donor pool is to do ABO incompatible kidney transplants. Okay, so that is what the patient agreed to. So this requires pre-transplant desensitization. So whatever ABO related antibody is there in the recipient, we need to remove that. How do we remove? By plasma exchange. And how do you inhibit further formation of antibodies? By giving rituximab. So in this case, anti-B antibody was lowered by means of these two to below 1:16. Transplant was done 37/2014. Last follow-up creatinine was 1.6. So it's more than 10 years and doing absolutely fine. So this is second way of expanding the donor pool. And the last example is 51 female, end stage because of chronic glomerulonephritis, wants kidney transplant, children ruled out by patient didn't want children to donate to them. Husband had a very high risk diabetes and hypertensive for long, high risk, no available donor was there at that time. Well, patient was from Satara, so started on peritoneal dialysis long back, and waitlisted for deceased donor, what we call earlier as cadaver donor transplant. So she was waitlisted for deceased donor transplant, which was done in June 2015. Donor was 29, male, who died because of road traffic accident. Later on, during the course from 2015 onwards, she had developed diabetes, had COVID in 20 or something, had angioplasty done in 2021, also had left metatarsal fracture, but still the kidney function in last follow was October is 0.96. So all these patients are examples of not straightforward transplants, and that is what I wanted to highlight is these are ways by which you can expand the donor pool and give them a very good quality of life for a very long period of time. A little bit of statistics from India. Annual incidence of end-stage renal disease in India is more than 2 lakhs. More than 2 lakhs new ESRD develop in India. In 2023, there were 13,642 kidney transplants done, out of which 85%, 11,794 was living donor, and only 15% was cadaver donor. Now, cadaver donor is something which we always promote because kidney donation or organ donation for that matter, we have got immense, huge number of accidents happening in India, road traffic accidents, and if we pull out all these, or maybe 50% of these to donate organs, I don't think anyone will require a living donor transplant. That is what is statistic. But unfortunately, the numbers are good only in southern and western part of India. East and north are still, even north, unfortunately, have very minuscule program, very small program. I mean, 1 or 2 in a year kind of thing. That is a stat story, unfortunately. We need to promote that. A small data in our hospital, we are not a very, we are young hospital right now in Manipal Med. In about 15, 16 months, 68 weeks, we did 68 kidney transplants. So 1 per week, out of which 12, that is 17% was ABO incompatible. So 1 out of 5 possibly is ABO incompatible, and 11 were cadaver donors, 16%, which is matches to about 15% of the national data. 1 out of 68 patients failed their kidney because of antibody-mediated rejection. So are deceased donor restricted transplant approved centers? The question, only transplant centers can retrieve the kidneys? Yes, no, or maybe this is for you to think. The answer is kidneys can be, or organs can be retrieved from transplant centers. There is a provision by the government that you can register yourself, even if you don't want to do a transplant, as a non-transplant retrieval center. So there are many centers in and around PCMC and PMC who can harvest the organs and give it to centers who are approved for doing an organ transplant. Not even that, there is non-transplant centers, so any nursing home for that practical matter, if they certify brain dead or brain death in their ICUs, the donors, the person or patient who is brain dead can be shifted to an approved center where harvesting can be done. Recently, last month only, we had one patient who was transferred from such nursing home. She was only 18 years road traffic accident and she donated all her organs. So she saved, I think, 5 or 6 lives in the community. So this is another which I missed out. I think they can highlight. The way we can expand the donor pool is something called marginal donor. So who have diabetes, predominantly for cadaver donors, diabetes, or even AKI during their stay in ICU, those patients can also donate organs. Last, I should not miss out on how to expand, when I'm talking about how to expand the donor pool, is xenotransplant. Not long back, 2021, US did a few, this was the first one, pig, which was genetically engineered pig. You cannot take out the pig kidney and just put it in the humans. So it's a genetically engineered pig whose kidney was transplanted in New York City. This is gaining focus now, and it's possible that maybe a decade or 5 years or 10 years down the line, probably we may not require human organs and pigs can serve, at least for kidneys, because kidneys has been done for transplant. So I'll cut it short. So to summarize, how to expand the donor pool? One is I showed doing a swap transplant. Another example I showed is ABO incompatible transplant, deceased donor transplant, and future maybe xenotransplant. So here I end my talk. I hope I am in time, and I would request both the chairpersons to give their experience and comment, please. Thank you so much.
Thank you, Dr. Jeloka, for enlightening us on such a wonderful topic and in time also. So basically, I fully agree with him. Rather than doing incompatible transplants, we can always go for a swap transplant, which is a better. But somehow the logistics become a problem in this case. So basically, in the city, if we establish coordination between the different hospitals where we can have a different blood group patient listed, and with the matching group, if we can do the transplant, that will be a better thing. Second thing, considering marginal donors in the deceased donor transplantation is the way we can expand the pool. There are few countries who are doing non-heart beating transplants also, but in India I don't think that's a possible thing, because everything over there is funded by the insurance, and here the most of them are funded by self. So taking such kidneys or organs from the non-heart beating donors will be a difficult situation in India, but at least we can accept the marginal donors. One. Second thing, if we have an interdisciplinary communication between the different hospitals, we can have a swap transplant, which is a possible thing which can be done. These are the two things that I think should be considered. And second thing, donor education. I mean, education in the society is the most important. When we counsel in the ICU for an organ donation, 50% of the time some clergyman or somebody comes, he says ki no, we want to try this way, that way, and I have seen at least 2 or 3 in last month who have deferred organ donation just because somebody intervened and later on the patient died and all the organs were wasted. So this is so education of the society is the most important in disease donor as well as in live donor transplants also, because in live donor transplant also the fear in the mind, if I donate the kidney, will I go on dialysis? That is the most important thing which occurs to donor, and that is why the sibling donations are deferred. That is what I feel. Sir.
Thank you for an excellent summary. As a government representative, you can understand what happens when you're sitting for an interview of the donor and the recipient. आपल्याकडे तर कोणावर the first principle is कोणावरही विश्वास ठेवू नका. हा माझा भाऊ आहे का ती माझी बहीण आहे, हे आधी पहिलं सगळं. The reason is that many of the time what the donor and the recipient are saying, हे अगदी खात्री केल्याशिवाय काही पुढे जातच येत नाही. But we have to go above this, कारण otherwise we are not ever going to go ahead with live. And as Dr. Jeloka mentioned, live related transplants once upon a time was the rate was quite good, but it seems to be now at least going down a bit because of small families and people unwilling to donate. At the same time, the results of live related are definitely much better, and I won't say very good as compared to cadaver, but they are better than cadaver transplants. The reason I think another thing which we could all do in our hospitals is to put up some display boards that cadaver, I mean, if there is organ donation and everything can be done, that might help to increase the organ donation. And probably what happens is, we would also request all those physicians that are there to because the patient is never admitted under a nephrologist at that time. So those physicians also, if they encourage, and the neurologist has to be pakka. त्यांनी सांगितलं पाहिजे हा गेलेला आहे. तुम्ही जर का म्हणायला लागलात नाही बघूया वाट पाहूया मग असं झालं की मग झालंच, मग ते काही डोनेशन कधी होणारच नाही. त्यामुळे द न्यूरोलॉजिस्ट हॅज टू बी व्हेरी फर्म की नाही याचा ब्रेन डेड आहे, आता तो काही ॲक्टिव्ह होणार नाही आणि आता तुम्ही याची ट्रीट. ऑफकोर्स अनदर थिंग दॅट हॅपन्स इज फायनान्सेस as he said for the cadaver donor, that comes into play. But what we have now decided is that we pay if both the kidneys go to whichever recipients, they pay for the maintenance of the donor for till the time that the apnea test has been done. So that is another important factor also which can help, because बरेच म्हणजे सगळेच गरीब असतात का नाही असं नाही आहे, पण काही लोकांची खरंच पैशाची ओढाताण असते, रोड ट्रॅफिक ॲक्सिडेंट ऑलरेडी बिल हॉस्पिटलचं बरंच झालेलं असतं, त्यामुळे मग त्या ठिकाणी अशा सॉर्ट ऑफ हेल्प कॅन बी अचीव्ड. दॅट्स वॉट आय थॉट मे बी अ हेल्पफुल factor in expanding the donor pool. And mind you, if you all think that live related transplant is very easy, it is not. You have to interview the donor maybe couple of many more times. I have had an unfortunate incident where the mother refused to give the kidney to the son, and that was at the 5th interview. So one has to be very careful while interviewing the donor. Please, as the treating physician, if you know the family well, then please interview the patient donor separately. But I'm just telling you out of experience whatever has happened. So don't take things for granted की आई आहे मग ती मुलाला देणार किंवा बायको आहे. एकदा असं तर झालं, एका बाईला असं आणलं आणि एनकरेज केलं ट्रान्सप्लांट करायला मुलांनी आणि मिस्टरांनी. तर ती मी आणि मग त्या सोशल वर्करनी बसून इंटरव्ह्यू घेतल्यानंतर मग आम्ही तिला विचारलं काय नाही, माझी एक चुलत बाई म्हणली माझी एक मावस बहीण आहे, ती स्वतः वकील आहे, ती दाखवेल ह्यांना सांगून की काय माझी किडनी कशी काढता येते. म्हटलं बाई राहू दे तुझी किडनी तुझ्यापाशी, नको घेऊ कोणाला काही. पण म्हणजे सांगायचं कारण की इंटरव्ह्यू हा बरेच वेळा आपल्याला घ्यावा लागतो. पण स्टील ॲज तरुण मेन्शन, transplant is the best modality, and this was by Dr. Mani even 20 years back when he had mentioned and discussed the various modalities of live related drugs.
Yes, I can. I agree with Dr. Ambekar. I had to cancel one transplant in the middle of the night when patient's donor was wife. She called me at 12 o'clock that I am not willingly donating the kidney, and the next day transplant was scheduled, so we have to cancel the transplant in that night, and we have to cancel every procedure. That can happen in live related transplant, even in related patients. Second thing, donor education, as I said, is most important, because now I can tell you 2 of my patients who were on dialysis have donated liver and other organs when they got into that situation. So motivation of the people is most important, and only it can be done with the education, nothing else. That we can feel. Dr. Tongawkar wants to say something.
Actually, I just want to ask one thing. What is the percentage of rejection? This we are talking about the donors. I am talking about the recipients. What is the percentage of rejection that we nowadays face in the transplant cases?
Rejection you are talking?
Yeah. So, and secondly, is there any issues in the long-term, follow-up, like maintenance and adherence to the immunosuppressive therapy by the patients? These are the 2 issues that I am really concerned about.
So rejection is about 20 to 25%. But then rejection for a common man, for understanding of the audience, I will tell you, please answer. So there are 2 types of rejection. One is cellular rejection, another is antibody mediated rejection. Cellular rejection, most of them come back to the line if you treat it with pulse steroid, etc. Antibody mediated rejection can also be treated with plasma exchange, IVIGs, etc. But there are chances that 25% of antibody mediated rejection may not survive, the kidney survive. So it's not very high. So what statistics I give to my patients when I counsel is that out of 100, 4 to 5 patients may not have working kidneys. The second part of question was your long-term immunosuppression. So I'll tell you, the statistics is about after 10 years, 50 to 60% of kidneys may not be working. One reason is, important reason, not number one reason, but important reason is non-compliance. So many of these patients do not adhere to drugs, may not be finance related, but they do not adhere to drugs. And that is the reason they fail their kidneys. Another
roughly monthly cost and why?
monthly cost is very minuscule, 8,000 to 10,000 rupees a month. It's not very high nowadays. But then out of, negligence, I would say, some have financial issues. There are many reasons. There is no one single reason. And the second important reason is antibody slowly develop building up in 10 years. So these are two common reasons for failing of kidneys beyond 10 years. But still saying that, still I think you'll agree, out of all renal replacement therapy, kidney transplant is still the best modality of treatment. I think Sir wanted to, and then Nagesh.
Thank you.
We never had this concept of swap donors. We thought it is live related donor means husband, wife or sister, mother, father, that's it. That's a new concept. But
Yes.
it's legally allowed.
Yes, it's legally allowed, and I'll tell you, IKDRC Ahmedabad is doing the maximum number of swap transplants, and it is number one center in the world basically, right? Number one center. And as Siddesh suggested, there are 2 or 3 different organizations who are putting in data for swapping, like IKDRC swap, Apex also is doing, and it's a good suggestion. We can do it locally in Pune also. So Sir is Secretary of Pune Chapter of Indian Society of Nephrology. I think you should take this lead and initiative and have a formal kind of a record keeping of patients who are waiting, who can be done for a swap transplant. Dr. Nagesh.
One more,
Yeah.
and second thing is, okay, we talk about recipients and their follow-up. What about the donor follow-up?
So donor follow-up, we always tell them they have to follow after 1 month, 3 months, 6 months, and 6 monthly. They have to follow either to the transplant center or locally to their physician. They don't have to come to the transplant. Many of the donors are from not from the local place, right? So they can follow up with the physician. We advise them. So normally, in general, hemogram, fasting blood sugar to rule out diabetes in future, urine routine examination, renal function test. Otherwise, a regular health package annual health package is good enough for them.
Common health issues for the donors afterwards.
Common health issues, what we tell them is some of these patients. So if I tell you the bad part is they can develop renal failure, go back to dialysis or transplant, 3 out of 1,000. So 0.3%. So it's not very significant. But since we have started taking marginal donors, for example, diabetics, hypertensives, elderly, last month we took a cadaver kidney from an 82-year-old gentleman. I think that would be the highest age in Pune. And yesterday, last month or maybe 15 days back, yesterday the recipient came for follow-up. Her creatinine is dropping, still dropping, is 1.77. So even with 82, the creatinine is quite decent. Right. So those are follow-ups. Yeah, doctor.
So what is the most of these transplant patients undergo repeated infections, mostly pulmonary and other UTIs. What is the contribution of these repeated infections in rejection? Is there any contribution? And,
definitely.
Yeah, and what modalities we can use to reduce these infections for preventing rejection?
Right. So infections are prone to induce rejections. There are certain infections which are more prone, for example, CMV infection. They are more prone to, because they are immunomodulatory, they lead to some immunomodulation in the organ itself. But all infections are prone to induce rejections. More so if the infections are severe, you tend to reduce the immunosuppression. So that also precipitates rejection. So that is, you're right. So infection. And number 2, what do we do to prevent infection? So all those infections wherein vaccinations are available, we try to vaccinate them prior. For example, pneumococcal vaccinations, hepatitis B vaccinations. All these vaccinations are routine for all pre-transplant period. And then flu vaccines, etc., etc. We give prophylaxis against common infections, for example, UTI, PCP, etc. for initial 6 months, and there are different protocols, different centers have different protocols, some use for many more years. In our center we use for 6 months prophylaxis with antivirals if you use stronger immunosuppressions. So prophylaxis, vaccinations, due care, explanation of them to lead a good quality of life, not eating at the roadside, all these preventive measures we do happen. Still they do land up into infections, sometimes severe. And infection is #1 cause of death in post-transplant period.
For diabetic donor, up to what level of microalbuminuria or serum creatinine level he can donate?
So there should not be any microalbuminuria, and so there should not be involvement of the organ because of diabetes. Then only we can take them. So now the Amsterdam classification have approved that we can take diabetic living donors beyond 60 years, provided #1 they do not have any end organ involvement, and #2 they are ready to comply with the guideline of maintaining their sugar under control and keep following up. So in nutshell, I mean there are other criteria also which will take time. Yeah, so no end organ.
You can even do a pre-transplant kidney biopsy and see for if there are any evidence. Abhijit, तुझ्या प्रश्नाचं उत्तर ते swap transplantचं एकच आहे. This thing is that the Maharashtra government till date does not allow swap transplant in between people who are not related to each other. म्हणजे the pair must be having first degree relation. म्हणजे बाबा एक माणूस जर का दुसऱ्या ह्याला देतोय तर त्याचा जो भावी डोनर आहे ही मस्ट बी फर्स्ट डिग्री रिलेटिव्ह, म्हणजे अगदी कोणा कझिन बिझिन किंवा काका मामा असं नाही चालत. ही मस्ट बी म्हणजे त्या जे डोनर जे रेसिपियंट आणि डोनर म्हणजे त्याचे फर्स्ट डिग्री रिलेशन पाहिजे. काही नाही त्यांचं पण इकडे दॅट स्टील नॉट अवेलेबल इन द म्हणजे युकेला नाही आहे पण महाराष्ट्रात आहे तसं.
Last month we have done one transplant. The donor came to me from Karnataka. A donor and recipient, husband and wife. They were Muslims. Another pair was Hindu from here, Pune. So we did the transplant, swap transplant. That is also done. So thank you.
Thank you.
I thank IMA-PCB and Manipal Hospital for giving us such a nice and pleasurable morning and feast, academic feast. Thank you very much.
Thank you, sir. I would like to ask chairpersons to felicitate Dr. Jeloka.
Sir, फोटो महत्वाचा असतो कारण आम्ही उन्हाळ्या करत नव्हतो सकाळी उठून
I would sir photo group photos. I would request Dr. Chinmay Ram to felicitate Dr. Ambekar. I'll request Dr. Raj Pol to do the favor, please. Dr. Chinmay, please felicitate Dr. Siddesh Dhaygude. Thank you all. So moving forward for our third session, which is based on PMT for common bone marrow disorders in hematology and oncology. I would request Dr. Kannan Subramanian to chair the session, please. He is a distinguished clinical hematologist with overall 30 years of experience specializing in bone marrow transplant, stem cell harvesting and chemotherapy. He is associated with leading hospitals in Pune, including Jupiter Hospital, Jehangir Hospital, and Sahyadri Hospital. Dr. Subramanian has successfully performed numerous bone marrow transplants to patients with complex blood disorders. He is pioneer in stem cell harvesting, advanced chemotherapy techniques in Pune, with significant outcomes. He is actively involved in many medical researches and educations, contributing to advancement in hematology. His expertise and patient-centered approach have made him trusted name in hematology. Dr. Jagdish Shinde, as in on stage. Dr. Jagdish Shinde is a highly skilled consultant radiation oncologist with over 13 plus years of experience in advanced cancer treatment. He has completed his MBBS from BJ Government Medical College, Pune, and has pursued his MD from Radiation Oncology from GMC and Regional Cancer Center, Trivandrum. Dr. Shinde specializes in advanced radiation techniques such as IMRT and IGRT and stereotactic radiosurgery, ensuring effective and target cancer treatment. He also has significant experience in total body irradiation for bone marrow transplantation. His commitment to innovation, research and compassionate patient care has made him trusted name in oncology. Welcome, sir. I would request Dr. Subramanian to introduce our speaker.
Good morning, everybody. I welcome Dr. Pol. I think, so he is again, Amcha Punyacha. He's a MD Medicine from BJ Medical College. And then he has pursued his hematology qualifications from accredited training program in Leeds, UK. And then he continued to a fellowship in bone marrow transplant in Nottingham, UK again. During this phase, he has been part of 3,000 autologous transplants for myeloma and lymphoma, and almost 2,000 allogeneic transplants, which included matched sibling, matched unrelated donor, and umbilical cord, and haploidentical bone marrow transplants. And he also has been part of 55 CAR T cell therapy, which is the newest cellular therapy that is on at present. He has numerous presentations in UK and European conferences and publications in internationally peer-reviewed high-impact journals. In Manipal Med, he has actually done 2 high-risk allogenic haploidentical transplants with many more in the pipeline. Over to Dr. Pol. Thank you.
Thank you, Kannan sir, for the kind introduction. I thank you, Manipal Hospitals and IMA-PCB Association for giving me the opportunity for doing a talk on the bone marrow transplant. I thank the chairpersons, Dr. Kannan and Dr. Jagdish Shinde. So, in the 20 minutes, it's difficult to cover the entire topic on BMT on common hematological problems, but we will go through the basic slides, and at the end we'll do one small case which we did recently. So BMT essentially means replacing the diseased bone marrow. The disease can be due to most likely malignancies. So these are the common indications for which we do BMT. One is leukemia, aplastic anemia, MDS, thalassemia, lymphoma, and multiple myeloma. Autologous BMT is the simpler form of BMT, which means we take the patient's own stem cells and give it back to him after a strong dose of chemotherapy. It is mainly done for myeloma and lymphoma. So this is the basic flow chart which explains how to do an autologous transplant. So, is this pointer? So basically, patients receive pre-treatment to release the stem cells from the bone marrow. Then we collect the stem cells of the patient by this harvesting procedure. As soon as we know that we have collected enough stem cells, we give the chemotherapy to the patient to eradicate all the disease. This is a very high strong chemotherapy. And then as soon as that is done, we infuse the stem cells back to the patient. And that is essentially autologous transplant. It normally takes at least 2 to 3 weeks for the new bone marrow to start producing new blood cells. Next we go mainly to the allogenic bone marrow transplants. So here what we have to do is we have to check the HLA matching of the donors. Ideally it has to be a 10 by 10 match. And these are the options which we can use as donors. Sibling transplants is the first priority. If there are no siblings and matched unrelated donors, which is from a national registry. In India it is the Dhati registry. If we cannot find these donors, then we can use haploidentical donors, which is parents if they are fit or grown-up children. These are by definition 5/10 transplants. And the last type of stem cell source, we can use umbilical cord. So just a basic understanding about the HLA, because that is very important for the successful transplant. So these are the HLA molecules which are on the white cells. So these help basically in foreign body recognition. So these are also the same cells which will determine whether the transplant will be successful or not. So these are on chromosome 6. And this is a real picture of a sibling transplant. He is the donor. This is the stem cell collection machine or harvesting machine. There are various companies. This is of Optia. Basically from one side we take the blood, it goes through the machine. The machine is very clever. We program it to collect only the stem cells, which are these stem cells. These bags are the stem cells. And after 4 to 5 hours of the procedure, we separate these stem cells and keep it separated. Rest of the blood we again reinfuse back to the patient. So this is the flow chart of how the allogenic transplant is done. So basically first we collect the donor cells like in the last picture. We process them, then the patient receives treatment to kill all the cancer cells, and then we reinfuse the donor stem cells. Although it looks like a very simple flow chart, it is in fact a complicated procedure taking at least average 4 weeks. Same time we are using effective immunosuppression medicines like anti-rejection medicines like anti-thymocyte globulin and cyclosporin. So this is a very important slide to help us to understand how a bone marrow transplant works. So BMT works by giving new bone marrow to cure the bone marrow cancer. It can also attack the organs, which we call as graft versus host disease. And at the same time, it can cause cure. So it is the skill of the transplant hematologist, transplant physician, and also some immune and non-immune factors of the patient and the donor, which will determine if the patient is cured or indeed if he has complications like GVHD. So these are the main side effects of transplant. One is graft versus host disease, which means the stem cells, they not only kill all the cancer cells, but they also try to attack the organs of the patient. Second is stem cell failure. The stem cells just don't start to produce new blood. You can attack the organs like liver, skin, intestines. Infections most commonly are CMV, and there is a high death rate in bone marrow transplant patients. So this is a slide of a GVHD patient where the stem cells of the donor have attacked the skin of the patient, causing this extensive rash. This is most likely stage 3 GVHD, but this skin rash can be even more severe than this, causing exfoliations and most likely Stevens-Johnson syndrome-like picture. This is the interesting case which we did last month. So it is a patient of ALL, acute lymphoblastic leukemia. She's 36-year-old and she is not responding since 5 years to chemotherapy. She has been to various hospitals, some hospitals have given up, and she's on the last palliative treatment. And she comes to us to see if there is an options. When we look at all the records, we find that she is chemotherapy refractory. She is not responding to any chemotherapy. So the plan is made to give her targeted treatment. Nowadays, you must have heard in cancer, some of the treatments are targeted, which means we target the leukemia without targeting the other organs. So we gave her targeted treatment called as inotuzumab. So this basically attacks the CD22 molecule on the surface of the cancer cell, and then it causes the blasts of the cancer cell. But even to this treatment, she is refractory. So now we are in limbo that she is not responding to any treatment. The golden rule of transplant is, if a BMT has to be done, they have to be first in remission, which means the leukemia should be in control. But in this case, she is not in control. So this is just a picture to show what happens when we deal with like these patients. So if you see, her age is here. She has relapsed multiple times, so she has only 4% chance of success if we give any targeted chemotherapy followed by bone marrow transplant. So given the data, we have more than 96% chance of failing the transplant. So we gave the traditional strongest chemotherapy just to see whether it will work or not. Fortunately, she went into remission. During the first week, when it was clear that she may respond, there is 50-50 chance. Same time we started the workup of the father who acted as a donor. This is called as haploidentical BMT. The donor was a father who was a 5/10 match. By the time of between 10 to 12 days, all her blood counts were 0, neutrophils were 0, platelets were 0, hemoglobin was 4 and 5. We are transfusing her daily. We did a quick bone marrow biopsy to see what is the status. Fortunately, she is in remission, but this cure is not going to be long term. It's only going to be a few more weeks before which she again starts to relapse, given her history. So this is the time when we should do an urgent BMT. So this is what we did in her case. We did the BMT and she was discharged last week. Yesterday we got the reports that the donor chimerism is 99%, which means the transplant is a successful transplant. So obviously now she's on a lot of immunosuppression drugs. So we are seeing her every week and trying to maintain the chimerism and the cure from the transplant. In Manipal Hospital, we can and we do all the types of BMTs. Thank you very much.
Thank you for this concise and easy lecture on bone marrow transplant. So if anybody feels that they have a question, they can go ahead and
As compared to renal transplants, how is the life after BMT and chances, like what happens in renal transplants? So after 10, 20 years, we do see a lot of chronic rejection. So what happens to BMT later on?
In this BMT, this was a myeloablative, the strongest transplant. The first 2 years are very important. This is full of infections, mainly viral infections. Then comes a phase of bacterial infections, then fungal infections. So we have to keep a very close watch on these patients. I like to see them twice a week and try to improve the things which are under the benchmark. So it is a very close follow-up. The most important risk is graft versus host disease. So we want to prevent that at all costs, because mortality from stage 3, stage 4 GVHD can go up till 80%. So these GVHD and infections are very important side effects of these kind of patients. Long-term side effects are also very common. So at least in UK and the Western world, there is a long-term BMT follow-up clinic, which we do once a month, where we are supposed to follow up the patients right till their extreme old age, because there are long-term lung side effects, cardiac side effects, Alzheimer's disease, and many more. So it's a very close follow-up for these patients.
In terms of survival, how good are they, like survival rates, 10 years, 20 years?
Depends on the patient's fitness and the disease. So before the transplant, we use a certain score, a calculator score, which tells us how many patients will live at the end of 1 year, how many patients will live at the end of 2 years and 5 years. In good risk transplants, like for example, if it's a good risk AML, the success rates or the remission rates or the cure rates are more than 90%. If they are poor risk, most highest risk of relapse is in the first 2 years in AML. If they don't relapse, then it is unlikely they will relapse in the next few years. That is as opposed to ALL, where they can relapse even at 5 years, 8 years, 10 years down the line. That is why close follow-up and similar counseling is very important for the patient. It's gone.
Can you do a bone marrow transplant more than once?
We can do, if a person relapses after the first transplant, we can do a second bone marrow transplant. So usually if the first transplant was a full intensity myeloablative one, second time usually we should do a reduced intensity transplant. So 2 times is possible. The likelihood of success is quite less in like these patients because of high risk disease. But if that is the only indication, that is done commonly also.
just few comments. For your question, sir, the bone marrow transplants are slightly different in terms of the duration of immunosuppression that is required. For kidney transplant, I believe it's lifelong. But in bone marrow transplant, because the immunity develops from the cells that you have transplanted, so it's during the first, maybe the lucky ones will get away even within say 6 to 9 months. The other people who develop GVH, there is, because of the GVH, you continue immunosuppression, and for some people it might be few years, maybe 2, 3, 4, 5 years, till the GVH is there. And in some patients, of course, you have complications related to chronic GVHD, which is like a chronic autoimmune disorder, and they might actually end up being on therapy for quite some time. And the other issue is in terms of the legalities and this one, it's actually much easier doing a bone marrow transplant as against a kidney transplant. So we don't have as many legalities because it's a cell that is continuously produced, you can take and you can give. And for repeat transplants, what you said, you end up doing a transplant for 2 reasons. Say a leukemia or a cancer, you do it because in spite of doing the transplant, the disease has relapsed. But at the time of doing the second transplant, the patient's condition sort of decides whether you will be able to do a second transplant or not. And then that can be done using a different donor, a different conditioning regimen, so that because the mechanisms are quite difficult to explain. So you try to make it different from the previous transplant. And you could also do for where there is a rejection, right? Rejection, a primary rejection, a secondary rejection. And again, the patient's condition will tell you whether you can go ahead and do a transplant, right? And you are allowed to only change the conditioning regimen in some cases, and if it is possible, you would also like to change the donor and then do the transplant. But everything ultimately depends upon the patient's condition, how well he will be able to do it. So if the rejection happened later on when the patient is in much better condition, maybe the success rate with your transplant also might be better. But if it is very early, primary rejections, many times it is quite difficult because the patient is already neutropenic fever, infection. All those complications would sort of decide ultimately what kind of success rate we end up having.
I would like to ask Dr. Jagdish Shinde, any comment on long-term, the first year or second year to keep watch as this patient has got PBI?
Yeah. The radiation has important role in transplantation, which is the total body irradiation. And in this total body irradiation, we do irradiation of whole body, so as to kill all the residual disease as well as as a conditioning for graft rejection. So the important side effects related to the radiation are lung-related side effects, like some patients might have pulmonary toxicities, some patients might have liver and liver toxicity, kidney toxicity. But the technique we are using in Manipal Hospital is rapid act technique. It is computerized and CT-based technique. So we actually know how much dose the organs are receiving. So our patient, I think there are no acute toxicities related to the radiation. So we need to see liver function, we have to see kidney function and pulmonary function in the short term.
Great, good, thank you.
Thank you, sir, for such an insightful session. I would request our chairperson to felicitate Dr. Rajendra Pol. I would request Dr. Chinmay Kumbhar to felicitate Dr. Subramanian.
Sir, come forward.
would request Dr. Mudit Maheshwari to felicitate Dr. Jagdish Shinde. Request for a group photo, sir.
सर थोड़े से पुढे या. Hold on. Thank you.
Thank you all. So moving forward with our next fourth session, it is based on osteoarthritis and avascular necrosis. To chair the session, I would request Dr. Govardhan Ingle to come up on the stage. He has been practicing senior pediatric orthopedic surgeon more than 20 years. He has been director of Ramakrishna Hospital and also has been attached as a practicing consultant at Deccan Sayadri and ONP Hospital. He has been elected as a president of Pune Orthopedic Society and has been serving as a joint treasurer for Maharashtra Orthopedic Association. He has attended many international and national conferences and CMEs as a faculty. I would request Dr. Hemant Patil to be on the stage to chair the session. Dr. Hemant Patil has been practicing orthopedic and joint replacement surgeon since more than 10 years with a special interest in pelvic acceptabular surgeries. He is an alumni from BJ Government Medical College. He has been associated as practicing consultant at LifePoint Hospital, Wakad. He has been youngest treasurer and secretary of IMA-PCB. He has been executive committee member of both PCMC and Pune Orthopedic Association. I would request Dr. Govardhan Ingle to please introduce our speaker.
Thank you PCB and Manipal Hospital for this nice session. May I invite Dr. Vinayak Ganate. He is from our own medical college at BJ Medical College, Pune, has done his graduation. Then he was also fellow of RCB Edinburgh, United Kingdom. He is an examiner of MRCS examination as well as for the AO trauma course in India. He is a specialist in hip and knee reconstruction as well as revision joint replacement surgeon. He also performed partial knee replacement surgery as well as a new trend is a robotic knee surgeries. His expertise in that, also he is a good arthroscopist as well as a sports injury consultant. So may I invite, and he is also member of IOA, Indian Orthopedic Association as well as Maharashtra Orthopedic Association, Pune Orthopedic Society and AO Trauma Association. With this I will ask Vinayak to please start his talk on OA and AVN. Thank you.
Thank you sir. Thank you for coming as a chairperson for this session. Thank you Hemant. So my talk is simple, the day-to-day problems that we see, and this covers almost 90% of the OPD's patients coming with the joint pains and back pains, and we'll just go in little superficial in these topics, not very detailed. So osteoarthritis, the most common osteoarthritis that is affecting Indian population or Asian population is the knee arthritis. And we already know that arthritis has a successful treatment in the form of total knee replacement. We have been seeing it in India for last 20-25 years. Western countries have been doing it for last 50-60 years. The results have been well established. We replace the worn out portion of the knee and put an artificial knee joint. It has a good life expectancy and a reasonable function. It makes patients independent again to do their daily activities. But now with the replacement, after 20 years, somebody at the age of 50 undergoes a total knee replacement. And again at the 70 or 75, probably this knee is not going to work. So we are looking at a revision knee replacement. So what can be done? With the number of increasing replacement, the number of revision rate is also increasing. If you look at the data, India does roughly about 500,000 knees in a year, which is second in the world. First is America, 800,000. But if we look at the population difference, India has a much bigger population, and probably we are not serving our population well. We are doing much lesser numbers in total knee replacements. We have seen 250% growth in India for total knee replacement in the last 5 years, and the mean age of total knee replacement in India is 65 years. But with the growing awareness and more number of surgeons available, the replacement age is coming down. But if we look at the lifetime revision risk for a person who undergoes a total knee replacement at 70 years, it's just 5%. That means they do not require a second surgery when they get a replacement at 70 or later. But if they get a replacement at 55 years of age, lifetime revision risk is 35%. It's jumped significantly. So doing a replacement in a younger population may not be the right solution. Because if the replacement fails, that means you are looking at a big surgery, removing all that prosthesis that we have putting the big rods and different prosthesis, and it doesn't have a good life span, the new prosthesis. It may last about 15 years or so, not more than that. So if somebody undergoes a replacement at 50 and 70 goes a second revision replacement, at 85 they are looking at a third revision, which makes the revision more difficult. And the function is also not great. So what are the alternatives for these total knee replacement in patients who are coming in a younger age? One of the alternatives is doing the alignment osteotomies, the high tibial osteotomies, or doing a partial knee replacement. These surgeries, they provide a near normal function of the knee. They maintain the biomechanics of the natural knee. So patients are able to perform 99% of their activities. But they have to be done in a selective patient to get the benefit. And these are time-buying surgeries and not the entire solution of the knee arthritis problem. So well done high tibial osteotomy lasts about 10 to 15 years. And that a patient at 55, if we get this, then he easily goes to the good replacement age, and then they can get a primary total knee replacement which suffices them for their life. Again, for the partial knee replacement, it is the same. And the reason for failure of partial knee replacement is not the failure of the joint as such, but the primary cause for failure is the arthritis in the remaining compartments. And then they require a total knee replacement, and that suffices them for their entire lifetime, and they may not require a revision knee replacement. So what we do in high tibial osteotomies, that's the normal knee alignment. The mechanical axis, I'll just tell it in brief. It goes through the center of the knee and the center of the ankle. And in arthritic knee, it develops a varus or valgus deformity, and that mechanical axis goes from inside. That leads to more loading of that compartment and more faster arthritis. Once the inflammatory markers are raised in the synovial fluid, it starts destroying the remaining part of the joint as well, which is not getting loaded, and that's how the tri-compartmental arthritis develops. So if we solve this problem by changing this mechanical axis alignment, then that loading gets reduced, and with anti-inflammatory medications and viscosupplementation, we can reduce the inflammation occurring into the synovial fluid and push the arthritic process by few years ahead. So we do an osteotomy into the proximal tibia. It is called, it's an open wedge osteotomy. We fix it with a plate and bring the alignment back to the center of the knee. And that way, the medial compartment which was developing arthritis and getting loaded, it gets unloaded and the arthritic process is pushed, and the patient buys more time before they require total knee replacement. It's a very successful procedure done for the right patient. It has selection criteria, and it preserves the natural knee. So we are not doing anything inside the knee. Everything is done outside the knee. So the natural knee movement and strength is preserved. Patients can sit cross-legged on the floor. They can use Indian toilets. They do not have any trouble. We do not recommend using Indian toilets in arthritic patients, but they can do it if they want in case of requirement. And it has a good strength. Like in total knee or partial knee, we say they cannot play contact sports or do impact activities. In high tibial osteotomy, that is not the case. So patients who require the knee to be stronger, like patients who are laborers, they are the good candidates because their strength is also maintained in the knee joint. So that's how the plate sits, and that's how the osteotomy is opened up and unloads the knee. So next option is the partial knee replacement. Again, partial knee replacement means replacing only the worn out portion. So we do only medial compartment or lateral compartment or patellofemoral compartment. There are three compartments. And the worn out portion is replaced. There are various different prostheses. Oxford has one of the longest data, and it has a mobile bearing knee. There are also fixed bearing knees. The robotic partial knee replacements are there. And it is a very successful procedure. When the arthritis goes into the other compartment, then we can always go in and change this to a total knee, and that will last them again very long time. So if the patients are not fitting into the selection criteria for a high tibial osteotomy or a partial knee replacement, then what should be done? So that's where the biomaterial advancements come. So now the research is ongoing and they are working on increasing the life of the prosthesis. The prosthesis which used to last for about 20 years, now it is come to 30 years. So Smith & Nephew has an implant called Journey. It is claimed to be 30 years. It's already proven into the factories by repeated loading that it lasts easily for 30 years. And that way we can offer this knee replacement in slightly younger age rather than waiting until 70 for reducing the revision risk. And the concept which is coming is one surgery in one life. If somebody, we time it right at the age of 60 and do a long lasting knee, probably that patient may not require a revision in their lifetime. Another new thing which is coming is the medial pivot knee. So we always get this from our patient that the knee doesn't feel like a natural knee. So on that also a lot of research is happening, and the biomechanics of a total knee are coming very close to the natural knee. The same way we pivot the medial compartment and the lateral goes in translation, the total knees are also coming in a medial pivot fashion. That way there is more high flexion in the knee, they get more natural knee, and what we used to call in the literature, which we could never achieve 10 years before, is a forgotten joint score. So that means we have undergone a total knee replacement. This thing is forgotten by patient at some point and they feel that their knee is natural knee. So that score is now become achievable. Patients with the medial pivot knee, the literature claims that after a couple of years, they are very close to the forgotten joint score. In total hip, we could definitely achieve it, but in total knee, it was becoming very difficult. But now with these new biomechanical knees, it is possible to achieve the forgotten joint score, and patients will feel that it is part of their body. So this is the next thing happening in total knee replacement. Total knee replacement has been blamed that it's been a painful surgery, the recovery is very difficult, and patients usually don't like it. They are stuck in bed, they mobilize late. So enhanced recovery is a pathway which was developed for gastrointestinal cancer surgeries in European countries, and then it was tried in every specialty, and it has found its success in total joint replacements as well. With the enhanced recovery, we do the pre-op optimization, the intra-op, the way we give anesthesia is different, post-op, the way we control the pain is different, and this way, doing a daycare total knee replacement has become a possibility. I used to do it in England as a daycare knee replacement. Patients get operated in the morning and goes home by evening. In Manipal Hospital, we have enhanced recovery pathway, and the patients get ready in 24 hours. So I operate today and next day morning they are ready to go home because they achieve all the targets that we have given. The patients are usually mobilized within a couple of hours after total knee replacement. The pain management is a multimodal. It's a multidisciplinary team. And there is also work done on patients' mental strength on this in the pre-op phase, what we call joint school. So it's compulsory for every patient to attend the joint school, understand what they are undergoing through, and be prepared for it. We solve all the related issues about the surgery, and that way we can achieve early mobility. That is also shown to benefit the pain management and requirement of painkillers when they mobilize within few hours after surgery. Because of the muscle and ligament stretching, the endorphins are released and they control the pain better, so we don't require much painkillers, and they don't get zonked with so many opioids. So this is one of the ERAS patient. You can see it's a high flex knee. She can do a thigh to calf flexion, and this mobility is 1 month post-op. They don't require any walking stick or anything. So that's the difference the ERAS makes to the patient's life. So now, coming to the second topic, avascular necrosis of the hip. Now, unlike arthritis, osteoarthritis, as we say, it's not a disease. It's a age-related wear and tear, or wear and tear secondary to a trauma or impact. But avascular necrosis is not like that. Avascular necrosis is a disease, and it occurs because of blockage of the blood supply into the femoral head, and the bone undergoes ischemia. It doesn't have any blood. So it's a condition very similar to heart attack. Only thing is, in heart attack, it has to be solved in a matter of few hours because the blood supply is stopped to the vital organ. It's an attack on the hip, and it is a little kinder. It has few weeks to months to solve this problem before it gets converted into a necrotic bone. So diagnosing it and picking it up early is the key in reversing and keeping them their natural hip. Recently, because after the COVID pandemic, we have seen an increasing incidence of the avascular necrosis. COVID being a vascular disease, it has multiple facets to it, but it has increased the risk of avian. And I usually see very young patients coming with the avascular necrosis of the hip. Those go undiagnosed and they come very late when the hip is already collapsed. And then we unfortunately end up discussing about replacing the hip rather than preserving their natural hip. So early diagnosis is the key in avian. These are the stages, and these are the X-ray stages, not the MRI stages. So if we see stage 1, the first stage of avian, we do not see any change on X-ray. So a patient coming with a groin or thigh pain, we do an X-ray, we see a normal hip. And this is what happens to the most of the patient. They were reassured in the OPD that yeah, everything is fine, you go home. And they sit on it, they take painkillers, 6 months are gone, a year gone, and then they get another X-ray, and suddenly they are in stage 3, where the hip is collapsed, and now we can't preserve the hip. Stage 2, 50% cases are picked up on X-ray, but still 50% may miss out. So the investigation of choice in stage 1 and 2 is an MRI scan and not an X-ray. Somebody is coming with a groin pain or anterior thigh pain, had COVID, got admitted, or on steroids. There are multiple factors, smoking, alcoholism, a lot of other factors are there. But post-COVID, what I say, if somebody has got COVID and they are getting a groin and anterior thigh pain, they have to be screened with an MRI scan of the hip. Because if we pick up stage 1 avian, we can preserve their natural hip. They don't require any surgery for it. Stage 3 and 4 are of course the collapse. So where the total hip replacement or the joint replacement surgery is inevitable, only we have to time it when they are struggling a lot. So in stage 1 and 2, before the collapse happens, we can start medications like alendronate, the bisphosphonates. And in literature, it has a proven record that it helps in reversing the avian in stage 1. In stage 2 also, it helps in about 75 to 80%. The research is done by our Indian surgeon, Dr. Sanjay Agarwala. He works in Hinduja, and I was his fellow for a year. And I have seen the results in my OPD as well. We have the patient since 1.5 years who is in stage 2. He's still maintaining on stage 2. He has not progressed to stage 3 with the help of bisphosphonate and the regimen. What else can be done to preserve the natural hair? Stage 2 and 3, core decompression is proven to be beneficial. Stage 1 also core decompression is beneficial in reversing. What we do is create a core into the bone that creates a channel, neoangiogenesis of the blood vessels grow in it, and the ischemia is reversed. We can also do multiple drill holes. We can add supplements into that core, and that also helps in reversing the ischemia in stage 1 and 2. Stage 3, it does help with the ischemia and the pain, but because the collapse has occurred, so arthritis is inevitable, and at some point they develop arthritis and require a total hip replacement. Now, total hip replacement, that's the last solution for a avascular necrosis collapsed hip. Is it a bad surgery? No, it's a very good surgery. It has been awarded as the operation of the century. So even if somebody has a stage 3 and 4 avian and they are struggling, I think this is their solution. We have a data of various implants from 22 years to 27 years with more than 80% survivorship for a total hip replacement. Uncemented ceramic on polybearing, and that gives them almost 90% functionality. Of course, they are not allowed to sit cross-legged on the floor. They are not allowed to use Indian toilets. They cannot do impact sports, but they can lead their normal life. They can drive, they can go to work, they can do all their functions. And arthritis of the hip is not a problem that cannot be solved, even if it's a stage 4 avian. So total hip replacement is a very good solution for patients who have missed their stage 1 and 2 and landed up in stage 3 and 4. There is another data coming up on this AVL because the patient population is very young. So some of the patients I have in my clinic who are on bisphosphonate therapy right now, they are 24 years, 25 years young boys or girls. And the question comes to mind that if they go to stage 4, should I be offering a total hip replacement to them? Because we know we don't have a data more than 27 years of one of the implant. So I do a replacement at 25 and at 52 they will require a big revision surgery on their hip. So what should be done? Should we delay it? Should we push it for few more years? The data also says that younger the patient we do total hip replacement, the revision rate is higher. It may not last 27 years because younger patients have more strength, so they impact their implants a lot and it causes an early failure. So we have to offer them total hip replacement. And why is that? A young chap who is starting his career, he has a lot of things to achieve in his life. They have a lot of responsibilities on them. Family, parents, the kids, society. They have to perform in their life. Losing out 2 years waiting for a total hip replacement and not doing anything is not a solution for them. They lose out on their career and they lose out their progress in their life. So the current evidence coming up is younger patients, the dynamics changes. If they are suffering and struggling and not able to even drive the car or ride a bike because of the arthritis in their hip, they need to be thinking about an early total hip replacement rather than waiting on it for a few years to push on and add more years to the prosthesis. Because after 25 years, probably the revision surgeries would be a completely different ball game. We may have robots to do it. And thinking about that future, that after 25 years I need a big revision, avoiding the surgery now and losing out life is not a good option for them. So total hip replacement is a very good surgery. If somebody has missed getting the diagnosis in stage 1 and 2, they should be thinking about it and not losing out on their life. So that's it about 2 topics. If you have any questions, sir, on any of the
Nice presentation, Dr. Vinay. Can you please elaborate regarding the lifestyle modification required post-surgery?
Post-totally replacement?
Both totally and totally.
Any joint. So finally it's an artificial joint. It is composed of different materials. And usually the bearing surface is a metal on poly bearing or a ceramic on poly bearing. So hard on soft surface. If somebody does a lot of impact on those surfaces like playing football, cricket, then that joint is going to wear out early. A simple analogy we can see is we buy a new car and if we drive it with 150 speed every day, that's not going to last many years. So it's our joint that we have to take care. We have to avoid impact activities. We have to avoid sitting on the floors. We have to avoid using Indian toilets. Even if the range of movement and function is there, then that joint is going to last very long for us. It's going to give service very long. The knee replacement is already lasting about 20 to 25 years. The hip we know lasting more than 20 years. And with the advancement in biomaterials, that life will increase further provided we avoid these impacts. So that is one lifestyle modification which is required by the patients.
Nice, Vinayak. Any role of this denosumab which is there in the market? There are a few papers, I think.
Yes. There is evidence coming up on denosumab, and I haven't tried it yet, frankly. But yes, once there is more robust evidence, I think that would be an option. It is getting explored. There are a lot of other regimes also under trial and getting explored. But currently I am basing my practice based on which is proven. That's why I am not experimenting. Maybe later on when I have a bigger pool with the consent of the patient, we can do a trial here and see if it is benefiting.
Basically this conservative mode of treatment in this AVN is what we are saying. So there are many people who are trying their own regimes like vitamin D supplementation, calcium supplementation, and they are coming out with the results. But stage 2B or stage 3 probably, still there is some not Yeah, not a real consensus or
Yes, there is no. But
yeah, I think joint replacement is really a good option
Yes.
for osteoarthritis. The patient life totally changes.
It changes.
That's
yeah.
true.
Yes, yes. Thank you. Yes, please. Mike, this side. Madam.
Sir, you said that there are restrictions of movements are there after the surgery. Like they have to use Western toilets and all.
Yes.
So does physiotherapy helps? Sir, one more question. Sorry to interrupt.
Yes, yes.
And if they're having a recurrence of pain in future, so does it get corrected by physiotherapy? And sir, if the joint is not working properly, is it again replaced?
Yes, revision you're talking about. The first question you asked is the restriction of the function. You see, the modern joints, the high flex joint, the range of movement built into the joint, triathlon or the high flex attune, it is from 0 to 150 degrees, which is equal to our natural knee function. So it's not the joint which is stopping that movement, but it's the ligaments and the muscles. We are forgetting one thing, that when we are doing joint replacement, we are just replacing the bony arthritis. And arthritis is an age-related wear and tear, right? The ligaments and muscles are also aging. They are also getting tight. So role of physiotherapy is definitely there. If somebody can get their ligaments and muscle again elastic, because they have become stiff because of arthritis, their collagen changes and more fibrous tissue forms. If it becomes more elastic, of course they will have more movement. So role of physiotherapy is definitely there. And physiotherapy is must. All these movements could be achieved only in first 1 month to 6 weeks time. So 4 to 6 weeks only. And we have already seen the patient doing a thigh to calf flexion after a total knee replacement. The movement is completely achievable, and that's the result of 90% of my patients, that they achieve thigh to calf flexion. But using toilets and sitting on floor has to be avoided, because it's not they can't do it. But when they are sitting down and getting up, the joint gets loaded in an abnormal fashion, and that reduces the life of the joint. So we do not want to do that movement and reduce the joint lifespan, right? We have seen Andy Murray undergoing a surface replacement of the hip. He went back in playing again, and then he worn out his joint very faster. He undergone a revision replacement again. So it's up to us how much we take care of that joint so that it will last very longer. Your next question, I forgot. You can just remind me again.
Revision surgery. Again, the
Revision surgery, yeah, of course it's possible. So if a joint fails, we can do a revision knee replacement and again restore the function. I do not have the photos of my revision patients here. They achieve also very good flexion and good movement. I have my revision done here. Manipal is about 1 year, 3 months follow-up. I met him yesterday only. And he does not require walking stick or anything. He's an 80 years gentleman. That joint will last him for his lifetime. Now he doesn't require a second joint after that. So it has a very good result.
Vinay, one more question.
Yes.
Is an robotic joint replacement is coming. For the knee, it's okay. It has a proven role.
Yes.
What about the hip, especially like in what is your own experience about doing it with the robo or without or what?
Yes. So robo is the latest addition in the joint replacement artillery. And having technology is always good, because technology guides us better and helps us achieve greater results than doing eyeballing and the conventional surgery. Robo has been here for just few years, about 6-7 years. Australia has it longer, I think. But the early data suggests that in total knee replacement, robo doesn't add much into the results. We will need longer data. Might be another 15 years before we know that robo is making a difference in total knee. But of course, it's not making the knees worse. But in total hip replacement, the early data does suggest that it is making a difference in implant positioning, and theoretically that will increase the lifespan of a total hip replacement. So robo is helping young surgeons to do more precise joints and give better results. So yes, robo is the way forward. It is going to stay here, not going to go away. But the myth that many people have is there is no actual robo coming and replacing a surgeon and doing the surgery. It's a computer navigation, right? It just guides real time to the surgeon. How is the cut being made? How is the balance going to be? So it's the surgeon who is holding the saw and doing all the cuts. It's not the robo doing anything. The robo is guiding with the help of sensors that at what degree the cut has to be done. How will be the balancing when I do that cut? So it gives that information in real time.
Yeah, it's like a Google navigation.
Yes,
it just keeps on showing you the right road, right path with less traffic, and where you will reach.
Absolutely,
like
sir. Very aptly compared.
I agree to both of you. In simpler words, it is quite an expensive way to do a average surgery.
Yes.
So most of the key joints what we perform on day-to-day basis, 90 to 95% joint replacement does not require robo.
Yeah, doesn't require.
It is only a select few cases which require assistance.
Yeah.
But considering the money power, it is being used as a expensive marketing tool.
Marketing tool.
And unfortunately, the common man is falling prey to it.
Yes.
Unnecessarily increasing the
Robo,
cost of entire hospitalization.
Robo is not necessary to do the surgery. All the data we discussed, 25 years, 22 years of longevity, is all conventional surgery. It's not robotic. Robotic doesn't have the data of even 10 years right now. So it is the future that will tell us if it adds to it or it makes it worse. So certainly it is not making it worse right now. Yeah. Thank you.
Thank you.
Thank you, sir. I would request our chairpersons to felicitate Dr. Vinayak Ganate. Now I would request Dr. Shrikant Madikattu to felicitate Dr. Govardhan Ingle. I would request Dr. Nikhila Sate to felicitate Dr. Hemant Patil. Request for a group photograph. Thank you all. So now we will move forward towards our inaugural session. I would request Dr. Chinmay Eram, our Head of Medical Services, to welcome the chief guest on the stage.
Good afternoon, everybody. We'll start our inauguration ceremony here. So I request Cluster Director, Manipal Hospitals, Baner, Mr.Anand Mote sir, to come on the stage. Also requesting Organizing Secretary of Med Connect, Manipal Med Connect 2025, Dr. Deore sir, to please come on stage. I request President IMA-PCB, Dr. Maya Bhalerao, ma'am, to please come on stage. Dr. Maya Bhalerao is a highly experienced consultant anesthesiologist with 29 years of practice in Pimpri-Chinchwad, owner of Bhalerao ENT Hospital. Alongside her medical career, she is an accomplished artist, curator and promoter of art and literature. She has held solo exhibitions at prestigious galleries, participated in international watercolor exhibitions, served as a national coordinator of the Art and Literary Club at the Indian Society of Anesthesiologists. She has also received multiple awards for her contribution in anesthesia awareness programs and social service. Additionally, she has also authored books, produced short films to promote awareness, and actively contributes to medical publications and organ donation initiatives. Next, I welcome Dr. Sarika Lonkar, Secretary IMA-PCB. I request her to please come on stage. She is an assistant professor in Department of Anesthesiology, serving since January 2021 at Dr. D.Y. Patil Vidyapit, Pune. With expertise in perioperative care and pain management, she plays a vital role in ensuring patient safety and comfort during surgical procedures. Dedicated to academic excellence and clinical precision, Dr. Lonkar contributes to both medical education and advanced anesthesia practice. I would also request Dr. Dilip Kamath sir, patron IMA-PCB, to please come on stage. He is a renowned gynecologist and obstetrician in Pimpri-Chinchwad, Pune, with nearly 5 decades of experience in women healthcare. Known for his expertise in high-risk pregnancies, infertility and advanced gynecological care, he has been a guiding force in the field. As a former president in the Pune Obstetrics and Gynaec Society and an active member of multiple medical associations, he combines experience with innovation to provide exceptional care for women at every stage of life. Next, I would request our keynote speaker for today, Dr. Vijay Dongre sir, to please come on stage. I will request Dr. Prasad to welcome him on stage. I have also would request Dr. Govardhan Ingre, President Pune Orthopedic Society, to please come on stage. I request all the dignitaries to please go ahead with the lamp lighting. Let's take a group picture. Seniors.
That's fine. Hold on. Thank you.
Now I request everybody please be on stage. Now I request Anand Mote sir to felicitate our keynote speaker for today, Dr. Vijay Dongre sir. I request Anand sir to also felicitate Dr. Maya Bhalirao ma'am.
Thank you.
Also requesting Anand sir to please felicitate Dr. Dilip Kamath sir. Now I request Dr. Prasad Deore sir to felicitate Dr. Sarika Lonkar ma'am. I also request him to felicitate Dr. Ingre sir, Govardhan Ingre sir. I request all the dignitaries to please be seated. I request Anand sir to say a few words of welcome on this occasion.
Good afternoon, the dignitaries on the dais, all the consultants and doctors who attended today's event. Thank you, IMA-PCB, Dr. Maya, Dr. Sarika Lonkar for giving us this opportunity. Manipal hospitals and Manipal, especially Baner, we strongly believe in connecting with doctor communities and doing these kind of patient education programs or doctor education programs to these kind of events. And this has been our continuous feature in last 2 years. Ever since Manipal had started, we started in August 22. And these 2.5 years, we have multiple programs that done with various associations on various scientific programs. And this will be our endeavor, that we will continue to have these programs and we'll need your support, and we'll always ensure that our consultants and our their knowledge will be available for sharing to these kind of initiatives. Thank you very much, and I look forward to have multiple such programs. Thank you.
Now I request Dr. Kamath sir to say a few words.
Good afternoon, the dignitaries on the dais, particularly Dr. Vijay Dogre sir, my IMA President and the Secretary Mahamanand Sarika Lonkar, Dr. Ingre and the most motto of CEO Manipal Hospital, my dear friends sitting in the audience, including Abhijit, and my youngest secretary. I'm really thankful that Manipal has come out with hands in hand with IMA-PCB. Basically, the things which I have seen for the last couple of days and couple of years, it's a nice thing that one of the end of Pune is again governing and giving the best possible services to the population of this area, which was a need of the society and which is expanding to this end of the Pune. You know, once upon a time, it's only the Ruby and Jahangir were the only hospitals, because I am the third generation which is looking after this particular thing. And now, the generation are expanding toward the other end. I used to call Purvekade and Paschimekade. तर आता पश्चिमेकडे वाढ व्हायला लागलेली आहे आणि त्याच्यात खरे हिरो जमायला लागलेले आहेत. अभिजित आहे, पंकज आहे. Because I know them for last couple of years working with me in Nirama Hospital. I really appreciate that the Manipal is extending with us, and we will be definitely extending our full support from IMA-PCB to Manipal in their any of the scientific as well as the progressive approach of medical education and the practices concerned. Thank you very much.
I request Dr. Maya ma'am to say a few words.
Respected dais, Cluster Director Dr. Mote sir, Dr. Dongre sir, Dr. Ingre sir, our father figure IMA-PCB Dr. Kamath sir, Dr. Deore, dignitaries of the dais, President-elect Dr. Sudhir Bhalerao, Treasurer Dr. Manisha, Dr. Abhijit sir, Dr. Hemant, all the esteemed faculties and chairpersons. A very warm welcome and good morning. This is a great endeavor that IMA-PCB and Manipal Hospital, they are in collaboration for the education, upliftment and the updates about our recent knowledges for the doctors. So it is really a great thing, and in future also we should collaborate in such way that we can impart this medical education to our colleagues. So thank you so much, and I heard the walkathon in the morning was a great event, and I congratulate the team for this great CME and walkathon. Regarding IMA-PCB, sir has already told, under the guidance of Kamath sir, we are marching towards excellence in our IMA-PCB. Since 10 years, we have done fantastic programs, and to be very specific, in last year, under the leadership of myself, Dr. Kamath sir, Dr. Manisha, Dr. Sarika, we have done fantastic program in such a way that we have done academic, non-academic programs, social awareness programs, to the great extent that we have crossed 52 number. So 52 programs we have done in 10 months. So this is just to strengthen the bond between the doctors. We had more and more inclusivity, more and more doctors, members of IMA-PCB were included in those programs, and I really thank my team for that, and I appeal here that we are having a membership drive program, and this membership drive program is governed by or is given by the IMA state, IMA national and our branch. So there is a huge slash of membership fees. So I appeal all of you, if you are not a member of IMA-PCB, please come forward and take the membership of IMA-PCB and get incorporated in our events. You can contact our Honorary Secretary Dr. Sarika for that matter. And once again, thank you so much, sir, and have a wonderful session post lunch also. Thank you.
I request Dr. Sarika ma'am to take over the mic.
On the behalf of IMA-PCB, we would like to have thanks for Mr. Anand Mote, Cluster Director, Manipal Hospital. I request Kamath sir to felicitate him.
This is a book I have written, Dhruva Bhramanti. That's a both pole I have traveled, and Arctic and Antarctica, and this is a small token of love from us. This is the IMA-PCB calendar, and this is again for the first time we have done this calendar. आणि घराघरात हे IMA गेलेला आहे, आणि विशेष म्हणजे महाराष्ट्र स्टेटने याला खूप अप्रिशिएट केलेला आहे.
I request our President Dr. Bhaya ma'am to felicitate Organizing Secretary Dr. Prasad Deore sir. Sir. I request Kamath sir to felicitate Dongre sir. I request ma'am to felicitate Dr. Ingray sir. Thank you Manipal Hospitals, Baner for associating with us for this CMA.
I now request Dr. Abhijit Joshi sir to launch our heart failure clinic and say a few words.
Good afternoon, all the dignitaries, PCB, IMA and Manipal Hospital. As we know that our population is aging, so many patients come with shortness of breath while walking, leg swelling, low ejection fraction, and sometimes even though the patients have normal or near normal ejection fraction, they still have these symptoms of breathlessness, that is heart failure with preserved ejection fraction. So to understand and to diagnose more of these patients and to give them best possible therapy, we have, as a Manipal Hospital cardiology unit, we are going to start this program of heart failure clinic. It's going to be a specialized clinic on every Wednesday of every month, second Wednesday of every month. So once a month, and between 2 o'clock to 4 o'clock, where we will try to assess the patients, their symptomatology, monitor their health from NT-proBNP, echocardiography assessment, as well as to guide them about the non-pharmacological therapy, which is generally kept aside or not given priority. So medical management as well as non-pharmacological therapy is very equally important in long-term management of heart failure patients. Also, those patients who require devices like heart failure devices, CRT, CRTD, also these patients can go for that. So every second Wednesday of month and between 2 o'clock to 4 o'clock. So we will be approaching you officially, but this is the launch. So thank you so much for that.
Thank you, sir. Thank you so much, sir. I want to take this opportunity to introduce our keynote speaker at this time. It is absolutely my honor and privilege to introduce today's keynote speaker at Manipal Med Connect 2025, a doctor whose life's work has been a beacon of hope and transformation in the field of leprosy care, public health and humanitarian service, Dr. Vijay Kumar Vinayak Dongre sir. Dr. Dongre's journey in medicine began in 1963 when he joined Ackworth Leprosy Hospital at a young age of 24. At a time when leprosy was not only a medical challenge but a deeply entrenched social stigma, he dedicated himself to a patient care, education and rehabilitation. Recognizing that leprosy was a multifaceted issue requiring a comprehensive approach, he played a pivotal role in establishing the RRE Society and the Bombay Leprosy Project. He also organized plastic surgery camps to help restore functionality and dignity to those suffering from leprosy-related deformities. He worked tirelessly with multiple organizations, including Society for the Education of Leprosy, providing treatment and support to some of the most vulnerable populations across Mumbai and beyond. He has also educated and inspired thousands, delivering over 10,000 lectures across India and presented his work at national and international conferences. In 1997, he took on the role of director at the Gandhi Memorial Leprosy Foundation, spearheading anti-leprosy initiatives across the country. Also served as a president of the Voluntary Health Association of India, where he played a crucial role in rehabilitation efforts following the Bhuj earthquake and the Odisha super cyclone. His remarkable contributions to medicine and society have earned him prestigious accolades, including the International Gandhi Award and in 2022, the Padma Shri, one of India's highest civilian honors. With over 60 publications, with over 60 publications to his name in English, Hindi and Marathi, Dr. Dongre continues to be an educator, an advocate and an unwavering force in the fight against leprosy and public health challenges. Today, as he takes the stage to deliver the keynote address, let us open our hearts and minds to the insight of a man who has not only transformed healthcare but also touched countless lives through his relentless dedication and compassion. So fellow colleagues, please join me in welcoming Dr. Deore sir.
व्यासपीठावरील मान्यवर आणि माझ्या बंधू भगिनींनो, जे आज इथे जमलेले आहेत. दिल्लीमध्ये मराठी साहित्य संमेलन चालू आहे, म्हणून मी देखील इथे मराठीमध्येच बोलणार आहे. मी आता 90 वर्षाच्या घरात आहे आणि त्यापैकी 61 वर्ष मी कुष्ठरोग निवारणाच्या कार्यात चंदीगड ते कन्याकुमारी आणि गंगटोक ते भुज असा चौफेर फिरत असतो. गेली 61 वर्ष मी हे कुष्ठ निवारण कार्य करीत आहे. मी आपल्याला सांगू इच्छितो की कोणत्याही प्रकारचं संशोधन मी केलेलं नाही. मी मूलतः आयुर्वेदिक स्नातक आणि त्यानंतर मला मिलिटरीमध्ये इमर्जन्सी कमिशन हवं होतं म्हणून अर्ज केला आणि मला सांगण्यात आलं बंगलोरला की आयुर्वेदिक लोकांना आम्ही घेत नाही. तेव्हा निराश होऊन मी मुंबईला परत आलो. मुंबईला आल्यानंतर 8-10 दिवसात जाहिरात आली कुष्ठरोग रुग्णालयाची की डॉक्टर हवे. मी तिथे गेलो. तिथे देखील हीच रडकथा, तुम्ही आयुर्वेदिक डॉक्टर, तुम्हाला काय येणार लेप्रसीबद्दल, कुष्ठरोगाबद्दल. त्यावेळेला मी त्यांना असं विनंती केली की MBBS विद्यार्थी आणि आम्ही GFM विद्यार्थी, आम्हाला 3 दिवस लेक्चर्स, 3 दिवस डेमॉन्स्ट्रेशन्स असतात लेप्रसीमध्ये, ती मी केलेली आहेत. आपण मला 3 महिने प्रोबेशनवर ठेवा. जर माझं काम तुम्हाला पटलं तर पुढे चालू ठेवा, अन्यथा काढून टाका. त्या 3 महिन्याचा कालावधी मी 34 वर्ष त्या हॉस्पिटलमध्ये काढला आणि या 34 वर्षामध्ये मी कमीत कमी 20 ते 25 कुष्ठरोग विषयक कार्य करणाऱ्या संस्थांना माझी मानद सेवा दिलेली आहे. आणि मी आपल्याला सांगू इच्छितो की त्या रुग्णालयात काम करीत असताना तेथील जे रुग्ण होते त्यांच्यामध्ये सांस्कृतिक कार्यक्रम मी घडवून आणले आणि त्यांना एक प्रकारे मी एक दिलासा दिला की तुम्ही देखील माणसं आहात, तुम्हाला देखील जगण्याचा स्वातंत्र्य आहे. आणि मीच नव्हे तर माझी पत्नी, माझी मुलं, आम्ही सर्वजण त्या रुग्णालयात जात असू, त्यांच्यात आम्ही मिसळत असू आणि अशा तऱ्हेनं मी त्या लोकांचा विश्वास संपादन केला. मी आपल्याला सांगू इच्छितो, हे करीत असताना मला मार्गदर्शन करणारे लोक होते फार मोठे. स्वर्गीय लीलाताई मुळगावकर, स्वर्गीय कुसुमताई वानखेडे, स्वर्गीय न्यायाधीश चंद्रशेखर धर्माधिकारी, अशा लोकांच्या हाताखाली मी काम केलं आणि त्याच्यामुळे मी काही करू शकलो असं मला वाटतं. जास्त काही बोलत नाही. 61 वर्षाचं अनुभव सांगायचा म्हणजे 61 तास देखील पुरे पडणार नाहीत. मी आपल्याला फक्त एवढंच सांगू इच्छितो की कुष्ठरोगाबद्दल सामाजिक कलंक असतो किंवा आहे काही ठिकाणी अजूनही. आपल्याला आश्चर्य वाटेल, ऋग्वेदामध्ये ब्रह्मवादिनी महाघोषा म्हणून जी विदुषी होती तिला कुष्ठरोग होता. तेव्हा तिने ऋचा रचणं थांबवलं. जे काही उपचार होते ते घेतले, बरी झाली, परत ऋचा ती रचू लागली. आपल्याला आश्चर्य वाटेल, रुक्मांगद राजा, सोमकांत राजराणी आणि भगवान श्रीकृष्णाचा मुलगा सांबा जो मदनाचा पुतळा होता त्याला कुष्ठरोग. तेव्हा श्रीकृष्णाने त्याला द्वारकेहून पाठवला ओडिशामध्ये कोणार्क या ठिकाणी आणि सांगितलं की समुद्रकिनारी झुडपं उगवतात, त्यांच्या फळांमध्ये बिया असतात, त्याचं तेल काढायचं आणि रोज सकाळी सूर्योदय होताना एक थेंब तोंडात टाकायचा आणि बाकी अंगाला चोळायचं आणि हा थेंब वाढवायचा दररोज, ज्याला आपण असं समजतो की रोज एक उद्या 2 अशा तऱ्हेनं त्याचा डोस वाढवायचा. आजही आपल्याला आश्चर्य वाटेल, कोणार्क या ठिकाणी अनेक कुष्ठरोगी असतात. त्यांचं एक समज असा की श्रीकृष्णाचा मुलगा सांबा जर बरा झाला तर आम्ही का नाही बरे होणार, म्हणून आपल्याला त्या ठिकाणी अनेक कुष्ठरोगी दिसतात. मी आपल्याला सांगू इच्छितो, म्हणजे मला मोह आवरत नाही, कुष्ठरोग, महारोग, लेप्रसी हे सगळे चुकीचे शब्द आहेत. लेप्रसी हा शब्द हिब्रू झरात ह्याच्यावरून निर्माण झाला आणि त्याचा अर्थ सडलेलं अंग. तर कुष्ठरोगामध्ये असं अंग म्हणजे त्वचा काही सडत नसते. दुसरी गोष्ट, कुष्ठरोग म्हटला तर सुश्रुत संहितेमध्ये 18 रोग आहेत, त्याच्यात एक अरुण कुष्ठ म्हणून आहे. हा अरुण कोण? तर तो सूर्याचा सारथी. सूर्योदय होण्याच्या अगोदर अरुणोदय, त्यावेळेला आकाशात लाल रंगाचे ढग असतात. तसे जर चट्टे अंगावर आले आणि संज्ञा नाही तर तो अरुण कुष्ठ. आणि महारोग, आपल्याला आश्चर्य वाटेल की चरक संहितेमध्ये एका मानस रोगाला महारोग म्हटलेला आहे. अयथार्थ अभिनिवेश, म्हणजे एकच व्यक्ती आज जितक्या दयाळूपणे वागते तितकीच ती कठोर आणि दुष्टपणाने दुसऱ्या दिवशी वागेल. तर अशा तऱ्हेच्या गोष्टी आहेत, सांगण्यासारखं भरपूर काय आहे. आपल्याला सांगू इच्छितो की 1948 पर्यंत तुवरक तेल आयुर्वेदातलंच आम्ही वापरत होतो, हिडनोकार्पस ऑइल या नावाखाली. 1948 मध्ये DDS आलं, डाय अमायनो डायफिनाइल सल्फोन, आणि मग 1981 मध्ये मल्टी ड्रग ट्रीटमेंट, रिफॅम्पिसिन, क्लोफॅझिमिन आणि डॅप्सो, आणि ते आजही चालू आहे. मी आपल्याला सांगू इच्छितो की केवळ सामाजिक आणि वैद्यकीय पैलू महत्वाचे नाहीत. आपल्या देशात आपला विश्वास बसणार नाही. कुष्ठरोग्यांचे मानवी हक्क पायदळी तुडवणारे 160 कायदे कानून उपलब्ध होते. आणि 1983 मध्ये आम्ही मुळगावकर बाईंना सांगितलं की इंदिरा गांधी तुमच्या मैत्रिणी आहेत, त्यांना सांगा, त्या पंतप्रधान आहेत, की एक तरी कायदा रद्द करून घ्या, कारण त्याची आवश्यकता नाहीये, कालबाह्य आहेत ते. सुदैवानं इंदिरा गांधींनी लक्ष घातलं आणि इंडियन लेबर ऍक्ट 1898 हा त्यांनी वसंतदादा पाटील यांच्या मार्फत महाराष्ट्रामध्ये कालबाह्य ठरवला आणि त्यानंतर इतर राज्यांनी त्याचा मागोवा घेतला. पण आजही काही राज्यांच्या मध्ये काही कायदे आहेत की वारसा हक्क नाही, शाळेमध्ये शिक्षण मिळत नाही, रुग्णालयात प्रवेश मिळत नाही. आणखी आपल्याला आश्चर्य वाटेल, एक काळ असा होता की लाईफ इन्शुरन्स कॉर्पोरेशन कुष्ठरोग्यांचंच नव्हे तर आमच्यासारख्या सेवकांचं देखील लाईफ इन्शुरन्स काढत नसे. आता हे सगळं बदललेलं आहे. आपल्याला सांगू इच्छितो मी की 1872चा ख्रिश्चन मॅरेज ऍक्ट, 1939चा मुसलमान मॅरेज ऍक्ट, 1954 आणि 55चा हिंदू मॅरेज ऍक्ट, याच्यामध्ये कुष्ठरोग असेल तर घटस्फोटाची तरतूद होती. सुदैवानं आता तो कायदा नाहीसा केलेला आहे. आणि कोणी केला तर वर्ल्ड हेल्थ ऑर्गनायझेशनने रेझोल्युशन केला, UNO ने केला, लॉ कमिशन ऑफ इंडियाने केला, आणि अशा तऱ्हेनं सरकारवर एक प्रकारे दबाव आला. आणि आजही विधी नावाची संस्था ही सुप्रीम कोर्टात काही कायदे राहिले ते कॅन्सल करून घेण्यासाठी, रिपील करून घेण्यासाठी कार्यमग्न आहे. माफ करा, आमच्यासारखा कुष्ठरोगी सेवक हा जास्त बडबड करतो, कारण त्या काळामध्ये तुम्हाला सांगतो औषधच नव्हतं, तर लोकांना त्यांना मानसिक त्यांचा आत्मविश्वास कसा वाढेल यासाठी फार बडबड करावी लागेल. मी आपल्याला सांगू इच्छितो राजकारण बाजूला ठेवा, या देशामध्ये ज्याने कार्यक्रम चालू केला कुष्ठरोग निवारणाचा ते होते महात्मा गांधी. आणि हे कार्य ॲक्सिलरेट केलं कोणी? इंदिरा गांधींनी. या गोष्टी आपण लक्षात ठेवल्या पाहिजेत. अर्थात त्यांना मदत करणारे होते डॉक्टर वार्डेकर, विनोबा भावे. आपल्याला आश्चर्य वाटेल, परंतु ह्या सर्वांनी कार्य केलेलं आहे. माझ्या सुदैवानं यापैकी काही जणांचा मला मार्गदर्शन घेता आलं. आता जास्त काही बोलत नाही, कारण आमच्यासारख्यांना थांबता येत नाही बोलताना. हेच कार्य आम्ही जास्त केलं संबंध देशभर. तेव्हा आपल्या सर्वांचे आभार मानतो. आपण मला बोलावलं, नाहीतर आमच्यासारख्या कुष्ठरोग सेवकाला कोणी कुठे बोलवत नसे. आपल्याला आश्चर्य वाटेल, 1970 मध्ये राजस्थानमध्ये आमचे जी रामू नावाचे कार्यकर्ते गेले आणि सरपंचाला विचारलं गावातल्या किती रोगी आहेत महारोगी. तो म्हणाला कसले महारोगी आले? महारोग आहेत म्हटला की आम्ही त्याला आत्महत्या करायला प्रवृत्त करतो. जलसमाधी, भूसमाधी, अग्निकाष्ठ भक्षण जे मनुस्मृतीत लिहिले ते आम्ही फॉलो करतो. माफ करा, पण अनेक धार्मिक ग्रंथामध्ये त्या काळाप्रमाणे अगदी चाणक्य नीतीमध्ये देखील असे काही कायदे होते की कुष्ठरोग्यांच्यावर फार मोठा सामाजिक अन्याय होत असे. सुदैवानं आता हे सगळं कमी होत आहे. आपल्या सर्वांचे आभार आणि इथेच थांबतो, नाहीतर तुम्ही मला थांबवाल म्हणून आभारी आहे.
थँक्यू सर, थँक्यू सो मच. थँक्यू. Thank you so much for your inspiring words. We will now break for lunch. I request Dr. Prasad Deore sir to give a vote of thanks.
Thank you all of you. I take this opportunity as an organizing secretary to convey my thanks first of all to IMA-PCB, Dynamic President Dr. Maya, Enthusiastic Secretary Dr. Sarika, and all the team IMA-PCB to be with Manipal to organize this Med Connect 2025. I also convey my thanks to Dr. Dilip Kamath and Dr. Gordon Ingre to be here and have their valuable presence for this inaugural session and the CME too. I am thankful to Mr.Anand Mote, who is our cluster director, not for only his support but his active participation in this CME. I also convey my thanks to all the speakers today, Dr. Abhijit, Dr. Tarun, Dr. Raj, Dr. Amit, Dr. Shruti, Dr. Vinayak, Dr. Prasad, and all the panelists from IMA and Manipal Connect. I am very much thankful and I convey my heartfelt gratitude to Honorable Padma Shri, Dr. Vijay Kumar Dongre sir. म्हणजे त्यांना अगदी मी एक प्रकारे हट्टच केला आणि अगदी कमी वेळेत त्यांना यायला सांगितल्यानंतर ते आवर्जून आले. खरं तर त्यांनी हा आशीर्वाद आणि प्रेमच आमच्यावर दाखवलेलं आहे. सर धन्यवाद. सरांचं काम इतकं मोठं आहे की सरांबद्दल कोणीतरी बोलायला पाहिजे, कारण सर बोलताना ते स्वतःबद्दल फारसं सांगत नाहीत असा माझा अनुभव आहे. पण कुष्ठरोग या विषयावर इतकं म्हणजे काम केलेलं आणि इतकं ऋषितुल्य व्यक्तिमत्व आज आपल्यामध्ये आहे, हे खरं म्हणजे आपलं सगळ्यांचं भाग्य मी समजतो. सर धन्यवाद. I also convey my thanks to Dr. Chinmay, Dr. Riya, all medical services team, Mr. Deepak Patil and sales team, Dr. Mr. Prasad Jadhav, Venkatesh and all the sales team. Thanks to Dr. Vishal and operational team. I am thankful to all the faces inside and hands behind curtain. आणि चुकून माझ्याकडनं कोणाचं नाव घ्यायचं राहिलं असेल तर त्या सगळ्यांचे आभार मी मानतो. I will be more thankful to all of you if you all will proceed to lunch and come back within time. Thank you. And I declare here that the inaugural session is officially over. Thank you.
Thank you, sir. We'll break for lunch, come back at 1:45 p.m. sharp. Thank you.
Lunch is arranged at cafe ground floor. His passion for advanced cancer treatment led him to Tata Memorial Hospital, where he completed a fellowship in thoracic oncology and robotic surgery, refining his expertise in minimally invasive and robotic assisted surgical techniques. He made a remarkable contribution in field of robotic surgery. He recently has achieved significant milestone by completing 100 robotic surgeries with his team. Congratulations, sir. His expertise in cutting-edge oncological procedure is evident through pioneering achievements including Pune's first robotic thymectomy and robotic Ivor Lewis esophageectomy. Dr. Jaipal Reddy continuously set a new standard in field of surgical oncology. Welcome, sir. I would request Dr. Shilpi Dolas to be on the stage. Dr. Shilpi Dolas is a consultant breast oncoplastic surgeon. She has overall more than 14 years of experience in breast cancer surgery along with reconstruction and aesthetics breast surgeries. She is currently associated with Ruby Hall Clinic since 2017. She has 14 international and national peer-reviewed journals and publications. She is editor-in-chief for Journal of Young Medical Researchers since 2016. She has been editor for Spandan. She is an association member of IMA-PCB. Welcome, ma'am. Now I would request Dr. Prashant Kotari to be on stage to chair the session. Dr. Prasad, he is a highly experienced general physician with over 24 plus years of experience in medical practice. He specializes in diagnosis and management of infectious disease, viral fevers and general health condition. He practices currently at Ashwin Medical Foundation, Moria Hospital, Multi-Speciality Hospital in Pimpri-Chinchwad. Dr. Kotari is a member of Maharashtra Medical Council and he remains actively involved in advancing healthcare standards. His dedication to preventive medicine, early diagnosis and effective treatment has made him trusted name in general healthcare. Welcome, sir. I would request Dr. Jaipal Reddy to introduce our speaker.
Good afternoon, everyone. It's my privilege to present Dr. Amit Parasni, sir. He is head of Department of Surgical Oncology and Surgery. He has more than experience of 25 years. We all know he is a senior surgical oncologist in the city. He has expertise in all the areas of surgical oncology, head and neck, gynecological, esophageal and thoracic surgeries. He has completed his fellowship in minimal access surgery from EFMAS. He has also done his fellowship in thoracic oncology from Tata Memorial Hospital. He has membership of a visiting fellow from New York, MSKCC and National Cancer Center, I guess, from Tokyo. He is a reviewer of many reputed journals, Indian Journal of Surgical Oncology, Indian Journal of Surgery and British Medical Journal. And he is an active member of Indian Association of Oncology. So, I welcome you, sir. Thank you.
Thank you so much for the warm welcome. All friends over here. Prashant, I know since 26 years. Shilpi here has been my student, erstwhile student, and now she's an esteemed colleague. And Jaipal Reddy is more than an esteemed colleague. So I am thankful to all of you for introducing me, giving me that warm welcome. And this is more of a philosophical talk. And I see that only the people who are really interested in seeing me are here for the talk. So I hope you enjoy it. The toss has not yet taken place, so let us wait that decision, what's going to happen. Why I have selected this topic is because there has been a recent change in my way of practice, or my place of practice. I shifted from Dinath Mangeshkar Hospital to Manipal Hospital, where I was offered a role of head of department and an opportunity to grow with the institute. A few names I would take, names of few institutions which I would take before all my talks, that is Tata Memorial Hospital, Dinath Mangeshkar Hospital, Niramay Hospital, of which the director of Niramay Hospital, Dr. Kamath, was here, is a father figure to me, and of course D.Y. Patil Medical College, where I spent almost 17-18 years working as a consultant. And through this short presentation, what I would like to convey to you is how surgical oncology practice or approach to cancer patients has changed, and how as members of the medical fraternity and medical faculty, we should know that patients, the management of a patient with cancer, how is it has changed with the years, and what should be done by the concerned specialists to give best outcomes. Okay. So, cancer is no longer a disease which one fears. Cancer, when I started my practice, only Inlax Budrani and Ruby Hall had radiation machines, and they were truly entitled to call themselves as cancer centers. And now I guess there must be not less than 7 or 8 radiation centers in Pune providing comprehensive cancer care services, and Manipal is the latest one of those. A lot has changed. There has been an influx of a lot of trained faculty, trained personnel in all branches of oncology, surgery, medicine, and chemotherapy or medical and radiotherapy. And so it is no longer a difficult or a very dreaded word, although we still have patients and their families telling us not to tell the patient the diagnosis. But more or less patients know that cancer is commonplace now. It is getting very common. Everyone has someone in the family or some friends who has been awarded the diagnosis of cancer, and they know that it can be cured, it can be treated, people can lead their normal lives after treatment, so that all can be done. And we all come from an era, we have come a long way from that era when cancer meant removal of organs, super radical surgeries, mutilating surgeries, big incisions, pain, bad chemotherapy reactions, bad radiotherapy reactions. We have come a long way from that. What does change is not only surgical techniques or not only training, but the ancillary branches which help us render the care for cancer, that is the branches being anesthesiology, nutrition and intensive care. So, and not to forget physiotherapy and rehabilitation. So all of these branches have tremendously helped us, or progress in all of these branches has helped us in improving outcomes both cosmetically and functionally and oncologically. Of course, there has been nothing short of a quantum leap in the advances in chemotherapy and radiotherapy and now targeted therapy, and that also can't be ignored. At one time, such medicines were not available and not accessible or not affordable to majority of the population, but now they are available, and whatever, I proudly tell my patients that whatever best treatment for cancer is available in the world is available in Pune at present. So no need to go anywhere else, it is available in the city, and I mean we are fortunate enough to live in such an era that we are able to give the best possible medical care to our patients. Coming to the commonest cancer in females in India and all over the world, breast cancer. When I was training as a surgeon, the breast cancer treatment was only limited to mastectomy, modified radical mastectomy. I come up from a time when removal of the muscle was not encouraged, and that was another generation behind me. But then we used to deal with gape wounds, then necrosis flaps, a lot of lymphedema of the arm. So all that is gone now. Better understanding of the disease, better techniques are now helping us to preserve more breast, remove less axillary tissue, cause less morbidity, give good cosmetic and functional outcome, and not make a breast cancer patient feel that she's an outcast or she needs to be, hide herself from the society, from her peers. So that is one big major advantage we have been able to achieve. More or less, we are able to give cosmetically good outcome with breast conservation surgeries, then maybe reconstructions, oncoplasties, And with all of these, we are also able to give radiation with an accelerated intent, giving radiation in lesser settings, thereby improving the compliances. And all this has resulted in lesser loco-regional recurrences and better overall survival. So this was the initial picture during my training when mastectomy was the norm, then came breast conservative surgery, and now we are doing flap reconstructions and oncoplasties so that the breast cancer patient should not feel that she is any different from any other women in the society. Interesting thing about esophageal cancer, when I was doing my training in Sassoon Hospital, I'm sorry to say, but we lost all esophagectomy patients which we did. So when I went to TMH for training, Jaipal, interesting thing, one of my ambitions was that I should see an esophagectomy patient walking home. And I could see that. I remember the name of the patient, Mrs. Srivastav, when I did a TTE for her, and then she went home. So I was very happy. I believe that an esophageal cancer patient can walk home and can go home. So we have again come up long way from that. We no longer use thoracotomies. Thoracolaparoscopic techniques and now even robotic techniques have made the incisions smaller, the pain lesser, and the recovery faster. Another thing which has changed is that for most of our esophageal cancer patients, we use neoadjuvant radiotherapies, most if not all squamous cell carcinomas. And I have not opened the thorax for esophageal cancer in so many years. I'm sure Jaipal will agree with this. So all this has resulted in improved respiratory function post-surgery, and good post-operative care and pain relief has improved outcomes. So esophageal cancer surgery has become like any other cancer surgery or any other normal surgery where recovery is the norm rather than an exception. The main cause was pulmonary morbidity, which was identified, and that has been elevated now with the advent of thoracoscopic techniques and robotic techniques. Rectal cancer, when I was training again in Sassoon Hospital, we used to dread when we used to get a patient of C rectum because that meant a colostomy, wound gaping, wound infections. There was no stoma care, no effective stoma care. I come from a generation which was young in the 90s, so there were no stoma bags, no stoma bags which were sticking to the abdominal wall, no paste, nothing. So we used to have a bad infections, bad skin reactions, excoriations, and managing a rectal cancer patient was very bad. There was not a very good concept of even divergent colostomy. So all this has changed. We no longer have to remove sphincters. We don't have to give permanent colostomies to patients. We can even salvage sphincters of patients with tumors as less as 3 centimeters to the anal verge by virtue of techniques called as intersphincteric resections. Another thing which has again changed over here is giving or very, very rampant use of neoadjuvant radiotherapy. One thing which I must try to convey to you is that radiation provides you with something called as possibility of negative circumferential resection margins or CRM, which is a very important concept in esophagus and rectum. And because of that, when we operate after giving neoadjuvant therapy, we get better margins, we get cancer-free margins, and we are able to provide better loco-regional and overall control. So this concept of giving radiation in situ is what has changed in the past 10-15 years. I mean, I'm sure Jaipal must remember this, that in the past 15 years we have not been operating CA rectums upfront. I mean, the lesions within 10 centimeters from the anal verge, we always think of giving neoadjuvant therapy first. And most of the times it is neoadjuvant radiotherapy with neoadjuvant small chemotherapy with a small dose with the intent to potentiate the action of radiation. So that has changed, better control, better sphincters preservation, and thereby better survival. Again, laparoscopic and robotic techniques have taken over open surgeries over here. It is a very, very commonplace thing to do a laparoscopic low anterior section, laparoscopic sigmoid colectomy, laparoscopic abdominal perineal resections, and again the surgical recovery becomes like any other major surgery. Head and neck cancer is the commonest cancer, one of the commonest cancers in Indian men. And when I was a trainee, we had a senior surgeon who used to do mandibulectomies without any reconstructions. And we used to call him that mansacha kutra karto because the tongue used to be hanging out. So patient you had to rely on rice tube feeding for his feeding, and there was no concept of adjuvant radiotherapy, and they used to recur in no time. So we used to actually make a patient more miserable by operating him rather than giving him any relief from his cancer. Now we know that with better reconstruction techniques like loco-regional flaps and free flaps, we do have a lot of patients recovering nicely. They are able to perform their duties in the society nicely. They have good cosmesis and good function. And with adjuvant radiotherapy, they are able to have 5-year survivals also, and sometimes or many times cures also. So this is what has changed in our practice of cancer surgery as regards head and neck cancer. From no reconstruction, bad morbidity, no radiation, to loco-regional flaps and free flaps, and now with radiation, even better survivals and cures. Gynec cancers, I've been dealing with gynec cancers a lot, and gynec cancers, I would like to mention two improvements in the past 15-20 years which have significantly changed the lines on which we manage gynec cancer. One is advent of radiotherapy. In previous years, cervical cancer was managed with surgery and surgery alone, and people used to have their bravado thinking that I can operate this, I can get the bladder away, or I can open the bladder, suture it again, I can do a colostomy. So that is no longer the case. We operate cervical cancer only in stage 1, and radiation, giving radiation has radically changed the treatment of cervical cancer in stage 2 and stage 3, and with good results and less morbidity. It is the norm now for treatment of cervical cancer. So this has changed a lot with good radiotherapy techniques. And another thing which has changed, not so radically but to a large extent, the management and the outcome of ovarian cancer is the advent of intraperitoneal chemotherapy. So the concept being that instead of giving the chemotherapy which acts against the cancer cells in the body, instead of giving it intravenously, it is given directly, or it is delivered directly to the peritoneum, where it is the cancer deposits are there. As we know, ovarian cancer or primary peritoneal cancer spreads by a contiguous method in the peritoneal cavity, and so this particular type of delivering chemotherapy would have much better results. So it has a proven role in recurrent ovarian cancer and some other peritoneal tumors also, and that has actually improved the survival of patients. Also in endometrial cancer, where we have a lot of obese patients of corpus cancer syndrome, it is now customary to do surgery by the minimal access route, laparoscopic or robotic, and with equally good results when you do a hysterectomy with a pelvic node dissection, and if required, a para-aortic lymph node dissection. So what has improved in the past few years is that cancer is not something which is managed by a single person alone. It is managed as a team after discussion of various factors in tumor boards. There has been a lot of improvement in availability of cancer specialists all over India because of increased number of seats in this particular super speciality, and qualified personnel are available not only in the cities but also in tier 2 cities like Ahmednagar and Satara and Kolhapur. Establishment of National Cancer Grid helps us in connecting with our peers all across the country and managing cases by thorough discussions. I would go ahead and say that cancer should be managed only at a comprehensive cancer center which has all facilities for management of cancer under one roof. I am proud to say that with Manipal Hospital and with the introduction of preventive oncology clinics on the occasion of World Cancer Day on 4th February, we now have all fields of oncology ranging from preventive to palliative care, going via therapeutics and diagnostics. So we have all possible oncology services under one roof, and then this is the best place, or a comprehensive cancer center is the best place for a patient to undergo treatment, because he will be attended by people from various specialties and various faculties, and only the right treatment would be given to the patient. Multi-speciality involvement in the form of involvement of pathologists, radiologists, nutritionists, and palliative care specialists will help us in providing the optimal care. So this is what sometimes we do. As we know, National Comprehensive Cancer Network guidelines are the guidelines which are used for management of cancer patients. So these particular guidelines are discussed, the patient's particular stage or type of tumor is found out over there, and the patient is given a printout of this document, and which proves as evidence of us giving evidence-based treatment to the patient. So this also helps in improvement of patient's faith with the person and the institution. I'm sure a lot of people must be doing this. So when a patient is suggested a particular treatment, and this particular treatment is potentiated by the guidelines which are governing all of the consultants. The patient has better faith in the management, and the compliance is better. So this is what we are doing now. What is to be avoided is hasty decisions. As a surgeon, I am proud to say that now we don't consider surgery as the norm for all solid organ tumors or as the first treatment. We would always consider neoadjuvant therapy, because we know that neoadjuvant therapy is something which will improve the surgical outcomes and the survival. We are cancer doctors, but before that we are doctors, and before that we are human beings. So what we need to understand is we need to give our best to the patient. Just because we are a hammer, everything should not look like a nail. So this is what has changed in my practice in the past 15-20 years, that I now know, I have matured, that I will not operate all patients who come to me. I will consider what is the best treatment or sequence for them, and the first treatment, if it's radiotherapy, if it's chemotherapy, that would be given first, and then he or she would be considered for surgery. So that is one thing which has changed. I will involve ancillary specialties earlier, palliative care, nutritionists. These are specialties which we forget, pain specialists. These are specialties which are available to us, which we forget, and these are most important to cancer patients because they want their pain relief first. They want their nutritional problems to be assessed first, but we only think about operating them or how we can get them to the operation table. So all these things have to be taken care of, and this as a mature surgeon is what I am doing right now. Latest technology is fine. Robotic surgery or targeted therapy, immunotherapy is fine, but we have to align our patients to the technology, not technology to the patient. This is something we should remember. So coming to the end of my talk, this is one particular exception which I had to make. Again, the thing being that you have a lot of rules to follow and you have a lot of guidelines to follow, but sometimes you just have to break your guidelines. This was a patient who came to me from Lucknow because I had operated on a member of her family 16 years ago. I had done an esophagectomy and he was a survivor. And this lady again, she came to me with carcinoma of the esophagus. She was 29 kg when she came to me. I couldn't think of operating her in my dreams also. But she said कि हम लखनऊ से आए, हमारे पास अभी कुछ नहीं, कुछ खाने को भी नहीं आता है. She wasn't able to swallow her own saliva also. They were not ready for radiotherapy, and giving radiotherapy was also not feasible to her because she was aspirating saliva. So we put in an endoscopic Riles tube for her. With difficulty we could put it. We gave her some nutrition, and then we had to counsel her. We did it as a team, the physician, gastroenterologist, anesthetist, everyone sat down as a team and counseled the family that this is the only option which we have. We would prefer to give her neoadjuvant therapy, but she can't take it, or you are not able to take it, so we will try to operate her. And there can be morbidity and mortality, but then the patient said कि कुछ नहीं होना है तो आप ही try कर लो. So we could operate on her. I tried putting a thoracoscope, Jaipal, but then she had a huge kyphoscoliosis, so I couldn't reach. So even open thoracotomy and finding the esophagus was difficult, but we managed it. She underwent surgery. This is her photograph 3 weeks after the surgery, and now she is eating. So this is something proud of. So I did not put this slide for getting applause. The thing is that sometimes you just have to eat your own words and do something which you have been trained to do for so many years. So I said thoracoscopy, so not possible. I said neoadjuvant radiotherapy, not possible. I just had to operate her. So such things, always you have to be ready for such things, and you have to make such changes in your practice. I think that I've come to the end of my presentation. Thank you so much.
The stigma associated or the morbidity associated with any surgery as such, with respect to head and neck oncology, the deformity, patient never asks whether I will get cured. He will ask, मैं अच्छा दिखूंगा ना. So that is what we meaning. So with all the branches, anesthesia, plastic surgery, all branches have evolved. So the surgery has not become a problem now. So thank you for summarizing it, sir, and thank you.
So it was very nice talk actually. I know Parasni sir from my PG days, I would like to say, and I was a fan of his surgeries. And I wanted to become one day like him or a part of him, and I'm glad sir that you have trained me very well. One thing I'll say that you are very, very good in esophageal cancers, which I have told to the Manipal Bangalore people also, to Dr. Zaveri and others. I worked in Manipal, and it's glad that the Manipal has got you. So it's kind of a diamond on a necklace. So I'll say that that is true. Sir, from the beginning actually he was telling us that it is not only to treat a cancer via surgery, but it is an involvement of other people also, which we understood over a period of time. But many people won't understand when the patient is walking in, they'll ask the surgeon why I should receive the chemotherapy. And they are scared more with the chemotherapy rather than the surgery. So, so what you want to say about that, means why we shouldn't get scared from that, and as a surgeon what we should say about the medical oncology part?
Herein comes the part of assuring the patient of best outcomes, because I'm sure patients must be coming to you to treat breast cancers, and patients are sometimes not willing to take chemotherapy. Neoadjuvant to छोड़ो, कुछ और भी नहीं लेना चाहते हो. So you have to tell them, and this happens when you are working under the premises of a comprehensive cancer center. That post that particular scenario, that particular environment gives the patient that confidence that I will be treated over here, and whatever this doctor will suggest, that would be the right thing for me. I think that something comes with the graying of hair also. That is also there, the fact. So more often than not now you will be able to convince people of taking the right treatment in the right sequence. So that is no longer a problem. Yes.
Correct. So we also do that actually. We'll convince the patient, but then patient will ask that why you are not operating when you are a surgeon. And I am one of the surgeon who will say that you can get operated by other surgeons, but I won't touch you until unless you will finish.
So sir, I'm glad that even I say that. I said that कि मी ऑपरेट करत नाहीये, मला करता येत नाही म्हणून ऑपरेशन करत नाही असं नाहीये. I think that this is the best treatment for you, and I think patients, somewhere in your body language, patients will understand that you are a surgeon, you are suggesting this treatment. Why you are? I sometimes even go to the extent and say की तुमचे ऑपरेशन करून मला पैसे मिळतील, पण मी ते करणार नाही आता. कारण का की what you need is something else. So it comes, definitely it comes. So one thing I would like to tell about Shilpi, when she finished her MS. She said, she came to me and said कि काय करूँ ये करूँ वो करूँ. So I was the one who suggested her कि breast oncology अच्छा branch try करके देखो, and she did. And then she came to me and said कि sir आपने बोला था इसलिए मैंने किया. Then it was the burden was on me कि now she should do well. So I'm glad that she is doing well.
So one more thing you said, not from the good doctors. So I was in search of the good doctors who are good in this.
So तुम्हारे सामने बोल दो sir, I was talking about her when I said कि panel देना है ना sir कोई को.
Actually, we are very proud to have Amit as a very good friend and a colleague. One more thing, from physician's perspective, what is important is that the holistic approach which has been taken over, which I was just listening to the story, that this holistic approach is very important because many times patients when they are diagnosed as cancer, the word जो आहे it's very a problematic word आणि तो villain आहे इंडियामध्ये. So because of that word, if you are diagnosed as cancer, त्या पेशंटची अर्धी हिंमत तिथेच संपून जाते. And when you have a holistic approach, it gives confidence to the patient also, the relatives, and it's very important because in our practice we see many a times they are very reluctant to ask complete questionnaire to a oncosurgeon or an oncophysician. राहिलेले प्रश्न ते physician कडे घेऊन येतात, frankly. And we are not able to answer them because we don't know what the exact problem is, what is the plan of action. So we really play a safe game not to talk too much. Here the role of team comes over, and many times what we have found as physician, the lacunae is in a good counselor, because whatever said and done, oncosurgeon, oncophysician or the other staff, they are not going to give that much of time to the patient, and the patient doesn't open up. The patient just opens up to the counselor The counselor spends half an hour, 1 hour with the patient, they start talking to them. And that is the area where we should make this team up, and a good counselor who can spend time with the patient, and that will become much more comfortable. This treatment, because advances are definitely there, we are going to advance over the next 10 years, 20 years also. The outcomes are going to be good. But this empathy and sympathy part should be taken care by the counselor very well, which will give the journey of the disease process, the treatment process and the outcome process much more smooth and better, and with minimum hassles.
A very good point, Prashant. The thing is that if the treating person, medical oncologist, surgical oncologist, the physician and the family physician, if they speak the same language, if the primary physician ratifies that this particular neoadjuvant therapy is the correct therapy for you, whatever your doctor has suggested, and does not send him to another surgeon, so that should be the language spoken by all of us, so that the patient gets the proper treatment which has been suggested to him in the first place. A very good point made by that everyone should be aware. The purpose of such CMEs, multi-specialty CMEs, is that everyone should be aware of different, treatment modalities or treatment approaches in different faculties.
Thank you, sir. Thank you all.
Oncosurgery without ego is a rarity.
Manus but without ego.
I know a lot of oncosurgery in Pune. You bring them any patient and they are ready to operate right now. Whatever happens to the patient, they are not worried. So it is very important to think about the patient, their outcomes, and at places you have to refuse the surgery. Even though I can operate, I don't want to operate. And that is the difference between the other surgeon and Amit. So thank you.
I would request all chairperson to just felicitate the participants. I would request Dr. Nagesh Darge to felicitate Dr. Prashant Kothari. Dr. Nayantara, can you please do the... I request Dr. Mudit Maheshwari to felicitate Dr. Shilpi Rose. I request Dr. Rajdatta to felicitate Dr. Jeloka. I request all along with Dr. Parasis to have a group photo.
Hello, mic check.
Come close.
Thank you.
Thank you all. Moving forward with our next topic, that is approach to stroke. To chair this session, I would request Dr. Rakesh Ranjan to be on stage. He is highly skilled and experienced neurosurgeon with overall 25 plus years of experience in field of neurosurgery. He is specialized in neurosurgeries, pediatric neurosurgery, neuro-oncology surgeries and advanced image-guided procedures in neurosurgeries. He has been active member in prestigious international and national medical societies such as Congress of Neurological Surgeons, USA, the International Society of Pediatric Neurosurgery and Neurological Society of India. Welcome, sir. I would also request Dr. Nihar Ingle to be on stage for chairing the session. He is skilled consultant neurosurgeon with overall 8 years plus of experience in neurosurgery. He is director of Kimaya Brain and Spine Center and is associated with Symbiosis University Hospital and Research Center. Dr. Ingle specializes in neuro-oncology, craniovertebral junctions, anomalies and other complex brain and spine conditions. His expertise and leadership in the field have made him trusted name in neurosurgery. I would request Dr. Rakesh Ranjan to introduce our next speaker, please.
It's my pleasure to be here and introduce Dr. Shruti Vatke. Dr. Shruti is a National Board Certified Neurologist with over 6 years of experience at Manipal Hospital, Pune. She has completed her specialty in neurology from Manipal Hospital, Bangalore. Her area of expertise include stroke, headache disorders, epilepsy and dementia. I would invite her to give a stroke lecture. I think
Good afternoon. First, I would like to take this opportunity to thank all the organizers of this event, Anand Mote sir, Deore sir, for giving me this wonderful opportunity to interact with you all. So let us discuss management of acute stroke. Since as practitioners, it is the most common neurological emergency that we all encounter. So we will discuss strokes under the headings. We'll first see the types, the risk factors of stroke, diagnosis and patient management. What is stroke? It is a neurological deficit which is due to acute focal injury of the central nervous system, which is usually a vascular cause. So the key words here are focal injury and a vascular cause. And that includes cerebral infarction, which is the commonest, also the hemorrhagic strokes, that is ICH and subarachnoid hemorrhage. Just have a look at the statistics. Estimated 1.8 million people in India suffer from stroke every year, which brings the lifetime risk of stroke to 1 in 5. So we can see how big this problem is, and still the awareness of the same remains quite low. Classification, a broad classification of stroke, 85%, that is the majority, are ischemic strokes, and the rest 15% are hemorrhagic strokes. That again includes intracerebral hemorrhage and subarachnoid hemorrhage. Just a visual representation of these broad types of stroke. The ischemic strokes are caused by a blockage of the blood vessel, which is due to a blood clot. And the hemorrhagic strokes are caused by sudden bleeding in the brain. So we remember it as block or bleed. Just a very broad visual representation. An image of subdivisions, ischemic strokes, they can be further classified as thrombotic strokes, which are due to a ruptured atherosclerotic plaque, embolus from a distant site, or lacunar strokes, which are due to lipohyalinosis of small vessels. Intracerebral hemorrhages and subarachnoid hemorrhages, they constitute the hemorrhagic strokes. Intracerebral hemorrhages are usually due to rupture of a weakened vessel, commonly associated with hypertension. And subarachnoid hemorrhages, it's basically a bleed in between the brain and its coverings. And they are usually due to rupture of subarachnoid aneurysms or AV malformations. Let us discuss the risk factors. First, the non-modifiable risk factors, that is, we cannot do anything to change these risk factors. The primary one is age. Stroke is a disease of aging. Increased age is associated with higher risk. There is a gender predisposition. In elderly males, the risk of stroke is definitely higher. There is a definite racial disparity in strokes, and genetics also play a strong role. That is, a family history of stroke would definitely predispose an individual to increased stroke risk. What we like to focus is the modifiable risk factors. That is, we can do something to control these risk factors. And we further classify it as factors which doctors can modify and factors which patients can modify. So the number one risk factor what we have to control as doctors is hypertension, because hypertension is the most important modifiable risk factor for a stroke. And it has a strong, direct, linear, continuous relationship between the blood pressure and the stroke risk. Diabetes is yet another important risk factor. Diabetics have almost twice a risk as compared to non-diabetic populations of the same statistics to develop a stroke. Also, it is associated with higher mortality whenever a stroke develops in an individual. Factors which patients can modify include cessation of smoking and alcohol, having a nutritious diet, drug abuse, that is cocaine, amphetamine. It is associated with increased risk for both types of stroke, ischemic as well as hemorrhagic, and physical inactivity, obviously. So why the talk, why the need for all this talk and awareness about stroke? Because now we do have therapies which the patient, if he is brought in a specific time frame, it allows to institute those therapies and have much better outcomes. So this brings us to the concept of this ischemic penumbra. So whenever there is ischemia to the brain, there is an area of dead tissue called the core, and that area is irreversibly infarcted. Around that area, there is a salvageable area, which means that if the blood flow is restored in time, that area function can actually recover. And this is the area that we are trying to target with all the newer stroke therapies. Be fast, a mnemonic which we all should be aware to spot the commonest signs of stroke. B stands for balance, if there is a sudden loss of balance. E stands for eyes, if there is sudden onset of blurred vision. F is for face, if there is drooping of one side of the face. A stands for weakness in arms or legs, and S is sudden speech difficulty. These are the common signs of stroke. T stands for time, so it means that it's time to call emergency services as soon as possible. And it is important to educate patients with risk factors, that is diabetes, hypertension, and their families, so that whenever they spot such signs, they can immediately call emergency services. So we saw that these are the commonest signs of stroke. Now we also know that different areas of brain control different functions. So obviously strokes in different parts of the brain will have different presentations. For example, if a stroke involves frontal lobe of the brain, there will be loss of limb movements. Also we know that the left side contains dominant language areas. So if it involves left frontal lobe, there will be Broca's aphasia. That is, the patient can comprehend spoken words but will have difficulty expressing themselves fluently. If there is involvement of parietal lobe, we all know it can present with anomia, that is problem with naming, loss of ability to write, impaired ability in calculations, altered consciousness, apraxias. These are the symptoms encountered in parietal lobe infarcts. If there is an infarct in occipital lobe, which is the visual processing area of the brain, it might cause defects in field of vision and defect in reading. It might also present with visual hallucinations. Temporal lobe infarcts, again, if it involves dominant temporal lobes, it will present with Wernicke's aphasia, where the comprehension of the patient itself is impaired. Brainstem infarcts would present with vertiginous symptoms, ataxia, dysphagia, that is difficulty swallowing, quadriparesis, altered consciousness. Cerebellar strokes, obviously with cerebellar signs like ataxia, slurring of speech, intentional tremors, and coordination difficulties. Let us see what are stroke mimics. So whenever patients present with these acute neurological symptoms, we suspect that they have a stroke. However, there are some conditions which can look like a stroke, that is stroke mimics. And these mimics, which are not actually strokes, they look like strokes, they account for approximately 1/4 of all suspected admissions. And it is very important to diagnose these conditions, because misdiagnosing them can have two adverse consequences. That is, if a stroke is missed out, it is diagnosed as a mimic, it might result in undertreatment of the stroke, whereas wrongly diagnosing a mimic as a stroke might result in overtreatment, like thrombolysis. A long list of stroke mimics, conditions which look like a stroke, ranging from simple conditions like migraine auras to demyelination, won't go through the entire list. We'll just see a few common mimics and the points how to distinguish it from a stroke. Hypoglycemia, the commonest mimic. The important point to remember here is in hypoglycemia, patient presents more with a global brain dysfunction, like an altered level of consciousness. Whereas in a stroke, the dysfunction is more likely to be focal, that is in one particular modality, that is either difficulty in speech or swallowing or arm or leg weakness or imbalance. A simple finger stick glucose can help differentiate between these two. Seizures and strokes, they are also mimics. But with seizures, usually there will be some history of, somebody witnessing a convulsion. Whereas in stroke, the history is usually some sudden numbness or weakness in one side. Yeah. Strokes might also have some history of epilepsy, or there might be a drug history that the patient is taking some anti-seizure medication. Whereas strokes are usually associated with vascular risk factors, that is diabetes, hypertension, or ischemic heart diseases. Vertiginous symptoms definitely confused with strokes, posterior circulation strokes. Important distinguishing point, in peripheral vertigo, the patient complaint is more of a vertigo, like that is a sense of rotation or giddiness. Whereas in strokes, posterior circulation strokes, the patients more likely complain of a sense of imbalance while walking. There are other distinguishing factors like the type of nystagmus, associated ear symptoms that can usually help us distinguish. Syncope, another stroke mimic. So we know it will have a temporary loss of consciousness. It might be preceded by the patient feeling faint, dizzy, lightheaded. Skin would be clammy, cold. And syncopes, we know they are more likely to occur in standing position unless they are cardiac syncopes, which can occur in any position. And most patients, they have a complete recovery on lying down. Let us have a look at the counterpart. What are stroke chameleons? So these are strokes which look like non-strokes, the opposite of mimics. For example, if there is a thalamic infarct, it might present with altered mental status, which is more of looks like a global dysfunction, and it might be confused with a metabolic encephalopathy. Also, as we saw, posterior circulation strokes, they can sometimes be missed because they are diagnosed as peripheral vertigo. Infarcts in basal ganglia can present with hyperkinetic movement disorders, which look like non-strokes. And the key point to distinguish between them, I think, is to look at the onset of action. Like stroke symptoms will usually have a very acute onset of symptoms compared to the non-strokes. What is the role of general physicians in teaching the patients to identify these signs and symptoms? Like we discussed earlier, it is very important to educate patients about, especially patients who have risk factors of stroke and their family members, because they are the ones most prone to get a stroke. It's also important to tell people to note the time when the symptoms began, because this has an implication with therapy. So the algorithm approach should be, if a patient is seen by you and you suspect that he has a stroke, it is important to refer to a center which has all the facilities like a stroke team, imaging, thrombolysis, mechanical thrombectomy and neurocritical care available 24/7, because time is of essence. Initially, the window of opportunity for IV thrombolysis is obviously 4.5 hours, but at expert centers, the window for mechanical thrombectomy still remains 24 hours. So it is important to keep our thinking open. Management of acute stroke, there is one singular aim, that is to restore blood flow and improve outcomes in ways that are rapid, safe and effective. And this is done by two ways. One is IV thrombolysis, where a IV catheter is placed and a clot busting drug is administered. The other way is direct mechanical removal of a clot called mechanical thrombectomy. So correctly selected patients, up to 71% of them, if they receive these therapies, they regain complete functional independence, and that is all the goal of all this talk about strokes. This slide probably is just to highlight the importance of time while dealing with a stroke patient. So we can see approximately 2 million neurons are lost per minute when there is an occlusion of a blood vessel of the brain. So this can tell us about the importance of every single minute when we deal with a stroke patient. How to approach a patient confirmed to have a stroke? So history and physical examination obviously remain the pillars of diagnosis. After securing airway, breathing and circulation, there are 3 Ds that I would like to highlight. One is the deficit the stroke has caused. So we grade it with NIHSS, can grade it as mild, moderate, severe. Like we discussed, it is important to note the time when the symptoms started. So this will help us know the duration of the symptoms, and we can judge whether the patient is in window period for IV thrombolysis, that is patient within 4.5 hours of symptom onset, or whether the patient is within 4.5 to 24 hours, that is still within the window for mechanical thrombectomy, or beyond 24 hours, which is completely out of window period. Important to know the drug history. So the exclusion criteria, the history on exclusion criteria has to be taken at the same time while you are evaluating the patient physically and grading the deficit. So important to know whether the patient is taking any anticoagulants or antiplatelets in the past, because some of this can definitely make the patient ineligible for IV thrombolysis. What are the mandatory investigations before undergoing any IV thrombolysis or mechanical thrombectomy? Only 3. All we need is a finger stick glucose, ECG and neuroimaging in the form of CT with CT angio or MR with MR angio. There are no other tests required. There is no need to wait for PT, INR, coagulopathy panels. Nothing else is required. That is all that we need to rule out common stroke mimics like hypoglycemia, and a neuroimaging to rule out a bleed. So as we discussed, after taking an accurate history, noting the time of onset, grading the deficit with a focused examination, ruling out high blood pressure and ruling out hypoglycemia, we do a neuroimaging, and if the appropriate contraindications are ruled out, the expected door to needle time is less than 60 minutes. That is from the moment the patient is brought in through the ER door to the moment when the IV medication is administered. The standard expected time should be less than 60 minutes. That is the standard of care expected at any stroke center. Just a few visuals on stroke imaging. This is an axial section of diffusion weighted images of an MRI. Diffusion weighted images are the most sensitive sequences to pick up acute infarcts. That is, they can pick up infarcts within minutes of onset. So image A, we see an area of diffusion restriction involving right MCA territory. On corresponding ADC sequences, we see a signal drop. Again, image A here is an axial section of CT angio. So we can see the right MCA totally cut off. Image B, we see the early ischemic changes which are seen on CT. That is, the right insular cortex shows a loss of gray-white differentiation. And on advanced imaging, that is CT perfusion, we see that the entire right MCA territory is at the risk of hypoperfusion. Coming to thrombolysis, within first 3 hours, according to HA, alteplase is the recommendation. The dose we know 0.9 milligram per kg. And if we rule out the proper contraindications, it can be used for all patients over 18 years of age. It can be indicated for mild as well as severe stroke symptoms. Within the additional 3 to 4.5 hours, there are some additional exclusion criteria that it can be used only for patients who are less than 80. The patient should not have a history of diabetes as well as a prior stroke. NIHSS should be less than 25, and patient should not be taking any OSCs. Evidence of injury should be involving less than 1/3 of the MCA territory. What I'd like to highlight is what are not contraindications. BP over 185 by 110, if it can be safely lowered, it is not a contraindication. Initial GRBS over 50. Like the changes we saw on CT, that is mild to moderate early ischemic changes on NCCT, they are not a contraindication. Patient taking initial antiplatelets, monotherapy or combination, that is anybody taking aspirin in the past, does not mean he has a contraindication for IV thrombolysis. And CKD patients who have a normal coagulation profile, they still can be thrombolized. These are not contraindications for IV thrombolysis. What are the contraindications? A current ICH, obviously not a candidate for thrombolysis, past history of ICH, coagulopathies, thrombocytopenias, active head trauma, recent surgeries, cardiac conditions including infective endocarditis, aortic arch dissection, basically conditions which predispose a patient to a high risk of bleeding. Obviously, these are all contraindications to IVT. Just a visual of stroke imaging before and after IV thrombolysis. So we can see before treatment in the diffusion weighted image, there is an area of diffusion restriction involving left capsuloganglionic area. And on the MR angio, we can see that the left MCA is cut off. And after thrombolysis, we still see the diffusion showing an area of restriction. But we can see the complete restoration of blood flow in the left MCA branch. What is a mechanical thrombectomy? It is a minimally invasive procedure which involves, so a catheter is navigated upwards from a large vessel, usually in the groin or in the wrist. It goes through the neck to the brain and it uses mechanical tools to physically pull out clots that are causing large vessel occlusion. So that uses a stent retriever or an aspiration catheter, and that eventually restores the blood flow in the blocked blood vessel. So I'd like to share an image of mechanical thrombectomy performed at Manipal Med. We can see here the first image. We can see it is a right CCA shoot and it shows a right MCA occlusion right from M1. And after a mechanical thrombectomy, we can see how beautifully the blood flow is totally restored and how the entire hemisphere would be perfused. We can see the length of the clot that was aspirated. So these are the patients which can have excellent outcomes following a mechanical thrombectomy or bridging therapy, that is IV thrombolysis followed by mechanical thrombectomy. Take home message: follow BFAST technique to recognize the signs of stroke early. Proper history and examination still remain the pillars of diagnosis. Common investigations are very simple. They include fingerstick glucose and neuroimaging. And it is important to refer to centers where facilities like imaging, thrombolysis, mechanical thrombectomy and neurocritical care are available 24/7, because that will make the differences outcomes, because time is brain. Thank you.
Very nice talk. I'd like to ask a couple of questions. Being a neurosurgeon, I'll be more interested about the surgical conversion of a stroke. As far as the posterior fossa strokes are concerned, do you follow the same thrombolysis guidelines which are for the anterior circulation strokes?
Yes, sir. So our guidelines are, usually we grade deficits using NIHSS. But as we all know that NIHSS is not a very accurate indicator of involvement for posterior circulation infarcts. But we would, we can have all the range of deficits. You can classify it all you want. But ultimately what is important in IV thrombolysis is any deficit which is considered disabling. So even if it has an NIHSS of 1 or 2, if we consider that it is a disabling deficit, like for example for any executive who has a weakness of right hand, it will still put him at an NIHSS of just 2, but we are still going to thrombolize. So same applies for posterior circulation infarcts, that if it is going to cause a disability in walking or maintaining balance, which will prevent him from resuming his activities. So any disability, like any deficit which is causing a disability for the patient, worth thrombolizing.
Thank you. Second is more so controversial question. What is the role of citicoline and paraxicam in the delayed treatment of a stroke? Because we know that whatever the trials say, but clinically how much does it help?
Sir, so yes, like you said, it's a very controversial question, because I think every person you ask that question will have a huge difference in their opinion. Like some people really believe in it, some people just say it's marketing or whatever. So there are some trials recently which show improved outcomes. So not just with citicoline, paracetam, there are newer molecules coming, Tyvalzi, you must have heard. So I would still say anecdotal, like whatever you follow, there are tiers of evidence, like aspirin or statins. These are the ones which ultimately affect the deficit, the disability and the survival. So I would believe that even if there are evidences, they are of not a level A evidence. Neither citicoline nor paracetam nor the other therapies which are upcoming.
Thank you.
Actually very timely kind of, and I think stroke is a huge burden. It's a huge burden to society and there is a huge need. How do you envisage setting a stroke ready center? Because I think it is one of the aspects where you need a multidisciplinary care and which is geared up to that outcomes. Where there are so many opportunities there and so many opportunities missed. So what do you think, what will bring any center to a stroke ready center?
Sir, so like, I would maybe just like to tell you what is followed at places like this or what we do at Manipal Med. So we do encourage that the teams notify, the paramedic team notifies the center well in advance so that they are ready. Also, there is some blast paging. So we do follow a system called the stroke code, where you page everybody involved in management of a stroke, right from the emergency physician to the CT or MR technicians, to the radiologist who's looking at the image, to of course the neurophysician on call, as well as make the cath lab ready. So I think that is one thing which helps a lot. Like, you anticipate a stroke patient, you have systems ready. That cuts out on a lot of delays. That helps.
Yeah, and are you using a CT scan or an MRI to stroke?
Yes, so again, all the older trials that came, they always had a CT based guideline because CT is what is available most of the times. Like many hospitals still will not have an MRI 24/7. Or there'll be some issue that the technician won't be available. So many centers even now, they do not have an MRI at night especially. At Manipal Med we do. So for us it is not a contraindication, but if we have to go by guidelines, they are always CT based.
So when we are talking about this hospital, maybe MRI what you might follow. But when you are talking to an audience like this, would you ask them to follow a MRI or a CT?
No, sir. So the idea is always to follow CT-based guidelines because it brings a delay. The guideline is not even to wait for any angiography. Like what I would personally follow is, or even if I do an MR diffusion, I wouldn't wait for an MR angiography. I would still thrombolize the patient before. Wouldn't spend 4 minutes doing an MR angiography.
This is a big issue. A lot of physicians who see the patient in the OPD, they will find a stroke signs. They will ask the patient to the MRI this. And because they are sitting in an OPD clinic, they will send the patient to down the stairs, all the windows gone, right? And by the time, so stroke ready center is paramount and the society needs to be totally upgraded. Like cardiology you cannot do without a cath lab. A stroke, because the outcomes are such, nobody feels like a stroke ready center is actually needed. I can also treat because there is no treatment. So there comes a role of having a center which can have everything under one roof and geared to provide the outcomes. Because it is even such a young population, young generation, they are having so many incidents of stroke. And every month we'll see in a BG center at least 10 to 50 missed stroke windows, which is such a huge burden to the society. So that is extremely important.
That is an excellent point, sir.
Thank you.
Thank you. Thank you.
Stroke, some interventions in there, more ideas because it's a hugely evolving change.
Any questions from audience? I would request the chairperson to felicitate Dr. Shruti.
Come close. Pudi up.
I would request Dr. Nagesh Dhaygude to felicitate Dr. Rakesh Ranjan. Also, I would request Dr. Suruchi Mandrekar to felicitate Dr. Nihar Ingle.
Nagesh sir, you have to be back on stage for a group photo. Thank you, sir. I think Dr.
Sorry to interrupt you, Dr. Lia. I take this opportunity to felicitate one more valuable person in between us. And I know that we got 234 registrations online with the Google form. The attendance sheet is showing that 120 around has attended physically. But considering the Bharat-Pak match, it is not an event that is going to tempt everybody and the minds of everybody. The doctors too are affected, but our observer is not. So I welcome our MMC observer, Dr. Milind Khedkar. I request our cluster director, Mr. Anand Mote, and IMA secretary, Dr. Sarika Lonkar, to felicitate Khedkar sir.
पुढं मागे पुढं येऊ मी त्यांना पुढं बोला सर थोडं पुढे या पुढं पुढे ओके
Thank you, Dr. Lia. Kindly proceed.
So, moving forward, last but not the least, so now we have a session on advances in gastroenterology, manometry, cholangioscopy and liver transplant. To chair this session, I would request Dr. Sudhir Bhalerao to come up on the stage. Dr. Sudhir Bhalerao is a renowned ENT specialist with over 25 years of experience and alumnus of Grant Medical College and LTMG Hospital, Mumbai. He is established the Bhalerao ENT Hospital and Laser Care Center in 2002, pioneering advanced treatments in endoscopy, laser and coagulation. Dr. Bhalerao has presented national and international researches with this latest study on COVID-19 published in Indian Journal of Otolaryngology. His excellence has earned him awards like Best ENT Hospital in Pune and Icon of PCMC Award. Welcome, sir. Also, I would request Dr. Manoj Srivastav to chair the session. He is highly skilled hepatobiliary and liver transplant surgeon. He holds a fellowship in liver transplantation from Global Hospital, Chennai, and specializes in living and disease donor liver transplant, as well as complex hepatopancreatobiliary surgeries. Dr. Srivastav expertise in managing various abdominal trauma and diabetic foot highlights in his commitment towards innovative strategy of surgeries. His researches on conservative surgery in diabetic foot further showcases his dedication in advancing surgical techniques and improving patient outcomes. I would request Dr. Manoj Srivastav to introduce our next speaker.
Hi, good afternoon everyone. It's an honor to introduce Dr. Prasad Phate. First of all, he is a very good friend. He is done his MBBS from Mumbai Grant Medical College, MD from BJ Medical College, and then Gastro from Lokmanya Tilak Medical College, Sion Hospital, Mumbai. He's almost having 15 years of experience into gastroenterology and liver diseases. He has completed his fellowship in advanced therapeutic endoscopy from Sydney, Australia. His area of expertise are chronic liver disease, diagnostic and therapeutic endoscopy, endoscopic ultrasound, hepatology, IBDs and pancreatic diseases, esophageal and anonectal manometry. So let's listen from him and increase our knowledge about this.
Thank you for the kind introduction. At the outset, I would like to thank the organizing team and Mr. Mote sir for giving me this opportunity. I am really privileged. My lecture is chaired by a GM site and a transplant surgeon. So today's topic is advances in gastroenterology, manometry, cholangioscopy and liver transplant. So I will not take much time. We are all waiting for the last few hours of India-Pakistan match. So there is a gap. We have to bridge this gap in the patient care. So there are cases of motility disorders like achalasia cardia, obstructed defecation or defecatory disorders which are not diagnosed on endoscopy. They need special techniques, special tests to diagnose these motility disorders, and those are diagnosed in the GI motility lab. The techniques used are anorectal and esophageal manometry and pH-metry. We all know that ERCP is the standard of care for CBD stones, but sometimes there are difficult stones, large stones. The shape of stones is difficult. They don't break easily, and at that time we need a technique called as cholangioscopy to directly visualize the stone and break the stone with laser. We all know liver biopsy is virtually replaced by fibroscan, which is a non-invasive technique to see the fibrosis of liver. We all know decompensated chronic liver disease, huge disease burden. Some patients do not respond to the optimization of treatment, and ultimately they require liver transplant. We are fortunate that we got our liver transplant license last month, and this hospital now is equipped to do liver transplant, and Manoj Sir's team is going to do the transplant over here. So before I start, I would like to give 1 minute for hepatitis B vaccination for our all healthcare workers. Being doctors and nurses, we all know the risk of hepatitis B. We all deal with blood, body fluids, needles, and we may get prick. We should all be getting vaccinated against hepatitis B, especially the class 3 and class 4 workers who actually deal with those needles and body fluids. So it's a very safe vaccine, hepatitis B vaccine. 3 doses are required. 1 ml IM in deltoid muscle, not to be given in gluteal muscles. It is highly effective, very few side effects, virtually no serious side effects. So what is a GI motility lab? We all know gastroenterology means endoscopy. So we hardly see any patient who has gone to a gastroenterologist and do not have an endoscopy report with him. But some conditions are not diagnosed by just doing endoscopy. We need motility test also. So we do have a GI motility lab where we do high resolution manometry, which is now the standard of care. So the catheter which goes from nose into the esophagus and then stomach is called esophageal manometry. There is another catheter which goes from below to check the anorectal function. We also use this anorectal manometric catheter to give treatment called as biofeedback. 24-hour pH and impedance metry is another technique which can really diagnose the unusual symptoms of like dry cough or cough which is not diagnosed, which may be related to the reflux disease. Colon transit time study, EGG, capsule endoscopy, motility capsule, and hydrogen methane tests are used for SIBO. So this is a long list of tests. We will just see 2 tests. So we all know that endoscopically we can diagnose the structural changes like strictures, ulcers, but manometry can be used to define the motility of the esophagus and the anorectum. So this is a classical picture. Right side is the normal transit of a swallow from upper esophageal sphincter to lower esophageal sphincter. We see a nice transition of pressure. The slide on the right side is showing a case of achalasia cardia where the lower esophageal sphincter fails to relax. Ideally, here we can see the relaxation in the pressure. Whenever we swallow, there is a alias relaxes and it allows the food to go down. With achalasia cardia, there is no relaxation of lower esophageal sphincter, and that is why there is pan-esophageal pressurization. Now on this graph, it is very easy to diagnose, but endoscopically you won't find any findings for this. The same thing is for obstructed defecation, that is a common defecatory disorder. So defecation is a complicated process which requires coordination of rectal and anal muscles. So anal muscle should relax and rectal muscle should contract, and patient also takes help of the abdominal muscles to give pressure. Sometimes what happens, because of some painful conditions in the anal region or some other causes, patient fails to relax the anorectum, and that can be diagnosed by anorectal manometry. The same catheter can be used to teach the patient that how to relax the pelvic diaphragm, and which is the now recommended treatment for defecatory disorders. So up till now, we all were using laxatives, different kind of laxatives, and patients used to abuse them to get rid of the constipation.
but biofeedback is the standard of care for defecatory disorders now. So this is the actual picture of the screen used for biofeedback. There is a graph which is showing the anal canal pressure, and we ask the patient to reduce that pressure. Because this is an involuntary muscle, patient has to understand and practice these maneuvers. We also teach patients to use abdominal muscles to create pressure in the rectum. So this is biofeedback for defecatory disorders. Now we will move on to the next case. We had a 78-year-old female, known case of ischemic heart disease, had obstructive jaundice and fever, that means cholangitis, and her MRCP was showing 2 centimeter stone in the distal CBD. So I would like to ask the surgeons in the crowd, what are the options we have for this patient?
Yes.
So we did her ERCP to get rid of the cholangitis, but a 2.5 centimeter stone, 2.7 centimeter stone is very difficult to pull down by just doing balloon sweeps, because it is too large for any balloon to be retrieved. So other options are to do the lithotripsy by ERCP. Like 20 years ago, before, the direct option was to do choledochotomy and stone removal. But now we did the same thing by putting a narrow scope, ultra thin scope through the ERCP scope, that's called as cholangioscope. We use a laser fiber and a laser generator to break that stone and clear the CBD. So this is the actual image of the stone. The small picture on the right side is showing ERCP image, and the bigger picture is of the cholangioscopic image of the stone. And here is the laser fiber, and the green light is laser light which is breaking the stone. So now this technique is available. It's called as cholangioscopy. We have a laser used by urology people. So we are using the same laser to break the stone. Now we will move on to liver cirrhosis. Now we all know that because of alcohol abuse, hepatitis B or C, now there is epidemic of obesity which can lead to NASH. Other causes of liver cirrhosis are autoimmune diseases, Wilson disease, PBC, PSC, cryptogenic cirrhosis. All these conditions will lead to liver cirrhosis. Even after some optimal treatment, medical treatment and dealing of complications, there is a subset of patients who do not respond, who repeatedly get hospitalized, and they only respond to liver transplant. So now there is a good treatment available for, good vaccine available for hepatitis B, very good treatment available for hepatitis C. So the percentage of patients for liver transplant having hepatitis B and C related chronic liver disease is decreasing. But now there is an epidemic of obesity, and NASH is becoming the most common cause of liver transplant, at least in urban areas. And alcoholic liver disease is also a huge subset. So we know that NFL is now becoming the most common cause of chronic liver disease, and our lifestyle is the problem. So the fatty liver or alcohol do not cause cirrhosis overnight. There are stages of development of liver cirrhosis. So initially there is injury to liver, it leads to fibrosis, persistent injury leads to cirrhosis, and it becomes irreversible. So once the patient has developed cirrhosis, we don't have much options but to treat the complications, and if the patient doesn't respond, do the liver transplant. But till the stage of fibrosis or early fibrosis, it is reversible. Unfortunately, there is no drug available right now which can reverse advanced fibrosis to the normal liver. Fibroscan is again a non-invasive test to diagnose advanced fibrosis, so that we have a prognostic marker which can tell that now fibrosis is advanced and we don't have much options. But it can also use to educate patients that some patients have F0 or F1 fibrosis, and that can be easily reversed, and there is no evidence of cirrhosis. So if the values are more than 12, then it is advanced fibrosis and cirrhosis. So these patients have very little options, but below 12 and 10, it is reversible fibrosis. Fibroscan has virtually replaced the liver biopsy, which was a good technique before, but it has involved some risk of bleeding and some risk of death also. So we have already seen the stages of liver disease. Once the patient develops cirrhosis, he repeatedly goes into liver failure. If patient has developed decompensation, that is any complication related to liver cirrhosis like jaundice, ascites, encephalopathy, SBP, hepatorenal syndrome, then the patient's life expectancy decreases rapidly, and this patient should be considered for doing liver transplant. So, natural history of cirrhosis, there is a long life in patients of asymptomatic compensated phase. So, once the liver injury starts, it takes at least 10-12 years for the liver to get decompensated or get damaged enough to cause decompensation. But when the patient develops the decompensation, then the life expectancy rapidly decreases. And this is the time when we should start evaluating these patients for doing liver transplant. Most frequent complications are ascites, bleeding, encephalopathy and jaundice. And following the appearance of these symptoms, we should consider this patient for liver transplant. Now, liver transplant is an excellent therapeutic option for patients who have cirrhosis and its complications, and it increases life expectancy significantly, and not just life expectancy, there is improvement in quality of life also. So these are the indications of liver transplant. If the MELD score is more than 15, we should consider those patients for liver transplantation. So I will not go through the detailed process of evaluation of liver transplant. We all know that we can get a cadaveric donor and a living donor. I think surgeons are better aware of this process. What I would like to mention is these statistics. So once a patient's MELD score is more than 15 or 20, 1 year life expectancy is very less. Or when a patient has developed SBP, spontaneous bacterial peritonitis, his 1 year life expectancy is around 20% only. The mortality rate is 80%. And liver transplant changes this. So current post-transplant patients and graft survival rates are 91% and 89% at 1 year, and 76 and 72% at 5 years, which is significantly higher than what we expect without liver transplant. So this achievement in the better survival is because of advances in surgical techniques, post-operative intensive care, improvement in immunosuppression and better patient selection. So we do have a liver transplant available in our hospital now. And we are continuously trying to bridge those gaps in patient care so that we have newer technology to help our patients. Thank you so much.
An excellent talk, Dr. Prasad. Just like to share some inputs. I had gone for a training in Coimbatore. That was in 2004. Dr. B. Anand. So one day he said that, Dr. Bhalera, we have to go to Ganga Hospital. This is almost 21 years back what I'm talking. But sir, what is there? We are going to see one procedure, and that is capsule endoscopy at that time. So that was the first time I saw the procedure, what exactly it was, this capsule endoscopy to it, and really how much now it has evaluated these things. Being an ENT surgeon, actually we also face a lot of patients, who has got difficulty in swallowing, and we do recommend esophageal manometry. But still, the field remains a little unexplored, I would say, in ENT sector to it. But definitely, we have to look into this aspect to it, yeah.
Sir, there is still a gap because we still can't evaluate the upper esophageal sphincter.
Yes.
The catheter which we have has a concentration of the sensors in the alias part only, because we are more interested in alias. So there is a solid state catheter which is not available in Pune, which has sensors in the upper part also, and that is the catheter which is recommended for evaluation of US. So still it is in the evolution phase. What we are doing for timing now is we pull the catheter till US and then do the evaluation, but there are no normal values available for Indian population. But we are getting that data.
Yeah. No, but now it is, a lot of even ENTs are recommending esophageal manometry
for it.
So upper
Yeah.
esophageal manometry is recommended before every fundoplication to make sure that esophageal motility is good.
Yes. Thank you.
Excellent talk, Prasad. I think you have said everything. There is nothing more to add. It's all about awareness about liver disease and obviously this manometry, because I think 60% of the population is constipated.
Yes.
So if you really go into it, there is a lot of work to be done. No, you see in OPD every alternate patient has a complaint of constipation. So
And actually we are left and right using laxatives and which is not the right way to treat it.
Yeah.
So we do have a dietitian who explains high fiber diet. We have a physiotherapist who tells them the Kegel exercise and pelvic floor muscle strengthening exercise, and then only I do the colonoscopy and manometry.
no, I think with gastroenterology progressing, I think this is going to be the part where most of, because colonoscopy, endoscopy, everybody is doing it. So and the problem is not getting solved. Problem is still there.
So they get the reports, patients, and then with report they come to us. Now you solve the problem. That is what is that.
But I think manometry should be the way forward for all this, because you will get the correct diagnosis. There are multiple things involved. It's not only about one thing. And liver, I think there is a lot of awareness.
Yes.
Let's start the transplant soon and give the, you can say, relief to patients, because they suffer a lot. Liver disease patients, they suffer a lot. Means once the repeated admissions, tappings, it's a huge burden for them.
It's not just the survival; it's the quality of life. Also.
Quality of life.
Thank you.
Okay, thank you.
Request our chairperson to felicitate Dr. Bhate. I would request Dr. Rahul Chaudhary to felicitate Dr. Bhalera. I would request Dr. Amit Parasnis to felicitate Dr. Manoj Srivastava. Rahul sir, you have to come back again for a group photo.
मला एक व्हिडिओ घेऊ द्या. पुढे या.
Thank you.
Thank you all. Moving forward for an interesting case discussion, I would like to call upon Dr. Rahul Chaudhary. Dr. Rahul Chaudhary is a USA trained orthopedic spine surgeon. He is heading the spine surgery department in Manipal Hospital, Pune. He has overall 18 plus years of experience. His expertise include minimally invasive spine surgery, microscopic discectomy, disc replacement, spine fractures, infections and tumor, spinal reconstruction, scoliosis correction. He has been active member in Pune Orthopedic Society, Maharashtra Orthopedic Society, Bombay Orthopedic Society, Association of Spine Surgeons of India, American Association of Orthopedic Surgeons. He has done his fellowship in spine fellowship at Twin Cities Spine Center, Minneapolis, USA Hospital for special surgery in New York, USA. Welcome, sir. Also, I would like to call upon Dr. Suruchi Mandrekar. She is a consultant in Department of Internal Medicine from Manipal Hospital, Pune, with overall 20 plus years of experience. Her areas of expertise are internal medicine, diabetes and asthma. She has completed her fellowship in Association of Physicians of India. She is a life member of Indian Medical Associate. She has been awarded as Young Scientist Award at European Respiratory Congress in Stockholm in 2007. I would request Dr. Rahul Chaudhary to introduce our next speaker.
I'd like to call upon Dr. Nagesh Dhaygude.
Hello, sir. So he's a consultant in Department of Respiratory Medicine in Manipal Hospital, Barnet, with overall experience of 22 plus years. Dr. Dhaygude is renowned for his expertise in flexible bronchoscopy, allergy testing, sleep medicine. Beyond clinical practice, Dr. Dhaygude is an international examiner for MRCP and PACE at the Royal College of Physicians, UK. As a manuscript reviewer for the Indian Journal of Respiratory Care, he actively contributes to the advancement of pulmonary medicine. His publications include international and national journals, original research on inhaler monitoring, oscillometry, COVID-19 case reports. So, yeah, please go ahead, sir.
Thank you for kind introduction, doctors, and thank you for the organizing committee for inviting and sharing this interesting case from Manipal Hospital. So, breathlessness and cough is a very common symptoms that we deal with in practice. Most of the time we are able to find out the cause, what is the cause of the breathlessness or cough. But some patients actually can be very baffling. The diagnosis can be very interesting, and it may not be, it is not possible to give them a diagnosis in first consultation. So I'm just going to present one such difficult case. So this was a lady which presented to our OPD, 54-year-old female with a long cough, intermittent breathlessness, and she had 2 admissions for acute respiratory distress, and one of the episode occurred in US where she was admitted. She was treated with all bronchodilators, steroids, and she underwent 2D echo and chest x-ray, and everything was okay. But when she came back to India, she had another episode of breathlessness, and angiography was done. The cardiologist thought it's a LAD block, so the angioplasty was done. But within few weeks after angioplasty, the patient was readmitted for breathlessness. So we have a patient who is suffering from intermittent breathlessness, whose cardiac investigation suggested probably she is ischemic heart disease, and necessary angioplasty was done, but still the patient was symptomatic. So when she was admitted after angioplasty, usually they take a check shoot, so they showed the well-functioning stent, and the echo was again normal, so they handed over to, probably this is a pulmonology case. The first bronchoscopy did not show much of the findings because it was probably done in a distress set. So this patient presented to us, and before I show you the next CT scan, this was how she was talking. Is it possible to? I think, what to call it? Just describe so you can listen to that. She has a strider sound when she takes a deep breath. Alright? this was her CT scan. So CT scan in sagittal, the trachea looked okay, and the only finding was only finding was the trachea was a little narrow, but the sagittal section showed this was okay trachea. So what we wanted to do is just to check what is actually happening with her trachea. Initially we thought, based on the CT scan, this could be some subglottic narrowing related to connective tissue or vasculitis, and that's why she is presenting like this. Or it could be a tumor in the subglottic area because the trachea looked a little narrow. And interestingly, the distal airway was patent. So so I'm going to play normal bronchoscopy on the left side of the screen, and this is the bronchoscopy of the normal patient to understand the difference, and on the right side the patient's actual bronchoscopy. So you can see that this is the accessory muscles are working, and she has this indrawing of respiratory muscle, inspiratory muscle when she is talking. So we went ahead with the bronchoscopy. So the moment we went inside, the trachea looked narrowed as expected. But as we went down, so it was further narrowed. There was loss of rings, normal tracheal rings, which you normally see when you enter into trachea. So this is, I'm just playing the loss of normal tracheal rings, but I approach the carina, which is collapsing. Normally the carina does not collapse so much. This is the carina, which is very much collapsing. On the right side, if you go, you can see that tracheobronchial tree is collapsing a lot, which is excessive dynamic airway collapse, which is not normal. And when you go on the left side, you don't see the opening of the left main bronchus. So this is not open, it's totally collapsed. So I pushed the scope down the left main bronchus, and as I went further ahead, I could pass the small bronchoscope, and then surprisingly, after about say 3-4 centimeters of a narrowed or collapsed segment, I could see the normal bronchial tree. Now this is now normal bronchial. So the area distal to left main bronchus was patent and open. And there was nothing endobronchial. So whole pathology was in the trachea, which was narrowed with the loss of normal tracheal rings and collapsed left main bronchus, which was able to open. So this is a case of tracheobronchomalacia, very long segment coming from subglottic to the left main bronchus. And this normally we do under sedation. So this so by they are immediately impedant post delivery, but as they grow older, the severity of tracheobronchomalacia reduces and they become almost normal. But what we deal with adult patient is usually the post-tracheostomy or post-intubation, where you see a segment of trachea collapsing. So it's a very localized tracheobronchomalacia that we see commonly post-tracheostomy or post-intubation. Sometimes we do see, because of mediastinal pathology like chronic fibrosing mediastinitis or sarcoidosis, or if it is because of some malignant mediastinal tumor resting on the trachea. So this lady didn't want anything surgical. The treatment would be surgically fixing the collapsed segment by tracheobronchoplasty, but such a very big surgery, she didn't opt for it, so we just prescribed her CPAP therapy during the night, and we stopped all her inhalers, which she was on chronically. So not all cases are obstructive airway diseases which present with breathlessness, and not they are always because of heart failure, as this was a primary suspicion in this patient because she had an angioplasty. So she spent a lot of time getting worked up in a cardiology site, but the cause was mostly the tracheobronchoplasia, which was worsening over a period of 1 year. So this is an uncommon presentation of a case of cough and breathlessness. Thank you. Sorry about the audio. Otherwise, I could make you hear the real strider sound she had while sitting in OPD. And this is the side you should look for. Thank you.
I would request Dr. Rahul Chaudhary to felicitate Dr. Rajdatta. I'll request Dr. Amit Thakurji to go for the presentation, please.
I think it's only all of us here at Manipal. Do I still need to introduce Dr. Amit Thakurji? I mean, it's a pleasure. He's a good friend and a greater surgeon.
That's why I have
Amit, go ahead.
So basically, good afternoon everyone. Today I am presenting a rare pathology for hemispheric epilepsy. So usually what we do in epilepsy surgery, either there are lobar pathologies like mesial temporal sclerosis or focal cortical dysplasia, and sometimes we have hemispheric pathologies like Rasmussen syndrome, which lead to refractory epilepsy, or prenatal, hypoxia or ischemia leading to hemispheric damage or multi-toxicity. But this was a very rare case, and it was an acquired pathology. So let's see how it went. So Mayur was a 4-year-old child, and he had normal birth, no perinatal insults as I told, and he grew as a normal child, normal developmental milestones. Till 6 months of age, he was fine, and then he had dengue, and then he fell from the hospital bed, and he developed a large frontotemporal parietal hematoma. At that time, he had altered sensorium and seizure. So he had a large hematoma, and he had to undergo decompressive craniotomy at that time in a local hospital, and the surgeon did a good job and he decompressed. However, he already had developed a PCA infarct here, which we can see. This was the pre-operative scan. You can see a large hematoma, must be because of the thrombocytopenia. So considering the mass effect, and we can see the post-operative scan done by the neurosurgeon has done really good job, but however, because of the raised ICP, he had already developed PCA infarcts. So then he recovered from that. This is a post-operative MRI done around 6 months after that. This is a Subramanian. In January 2017, at the age of 3 years, so he recovered from that insult after the decompressive craniectomy. He suddenly developed acute left-sided weakness. So initial insult was also on the right side of the brain, and MRI this time showed a right parietal hematoma. So he was managed conservatively. This time he did not undergo any surgery, and we can see now this is a new hematoma which has formed in the parietal region. This is the centroparietal cortex bang on the hand area and the leg area. And this is the initial sequelae of the initial insult. So the frontal lobe was damaged, and as I said, the PCA infarct was already set in. So he was managed conservatively. However, now we understand that he has undergone a hemispheric insult in the form of frontal, parietal as well as an occipital pathology. And this is an acquired thing. So January 2018, 1 year after that, his hemiparesis slowly improved. However, he started developing attention deficit hyperkinetic syndromes and started having seizures, which were almost daily. And he was put on multiple anti-epileptic drugs, one drug after the other. Despite of that, his seizures could not be controlled. The seizures were typically focal with the left upper limb stiffening and a staring look followed by brief unresponsiveness. So the seizures were not GTCS, they were focal hemispheric seizures. Examination findings, he had very poor attention, seldom eye contact, and what we call it as epileptic encephalopathy. Because of repeated seizures, these children have regression of milestones. They go back in their milestones, and he hardly used to speak few words. Very hyperactive though, left-sided hemiparesis, but he was able to walk with a hemiparetic gait. So this is the kind of seizure he had. His parents were farmers. This is a typical home video which we asked them to capture. And the left upper limb posturing and unresponsiveness. So typically these seizures are arising from the right hemisphere, which we can see clinically. And this was the scan done at this time. Because of the repeated seizures, he underwent pre-surgical evaluation, and we can see the frontal, the occipital as well as the parietal lobe are damaged. So hardly any functional tissue is left except for this parasagittal strip of brain, while the left brain is normal. And now the child has hemiparesis but daily seizures, around 6 to 7 episodes per day despite of multiple antiepileptic drugs. This is the flare image. So the final diagnosis was medically refractory epilepsy secondary to post-traumatic right hemispheric gliosis. And in view of these multiple daily seizures, regression of milestones, high frequency, and unresponsiveness to multiple antiepileptic drugs, we decided to go ahead with hemispheric disconnection. So typically what we do in these cases, we disconnect because all the seizures are arising from this hemisphere and they are being propagated to the other hemisphere. And that is why they are going into epileptic encephalopathy. So we disconnect this hemisphere from the other hemisphere. And that is how we prevent seizures from happening. So even if the seizures are generated, they remain only in this hemisphere and are not propagated to the other hemisphere. And that is how they become seizure free. So it's a major surgery, hemispheric disconnection, in which we do the corpus callosotomy. We disconnect the corpus callosum, that is the bridge between the two hemispheres, and we do hippocampal disconnection also. What I practice is a De Villandez approach, that is a vertical parasagittal approach. And this is the old scar. The poor child had already one major surgery at 6 months of age. So this is the bone margin which I have marked, and then a fresh flap I designed for the hemispheric disconnection. It is done typically through 2 by 3 centimeter corticectomy. We enter the lateral ventricle and disconnect the brain from within. So these are the disconnection cuts. I won't go into the details. And we keep the central core intact, that is the caudate and the thalamus and the basal ganglia, and the rest of the brain we disconnect. So this is the central core which I was talking about. This is the insula, this is the caudate, this is the basal ganglia, lentiform nucleus, and this is the thalamus. So typically the disconnection starts from here and it goes from the claustrum or the inside of insula and reaches the frontal horn. This is how the central core remains intact while the rest of the damaged hemisphere is disconnected. So you can see this is the post-operative scan. This is the disconnection cut going from lateral to posterior. And this is the basal disconnection. This is post-surgical scan. So this is how the disconnection looks. The central core remains intact, otherwise it will develop permanent weakness. So he had lactic acidosis in the post-operative period, which was corrected. He was discharged on day 7 typically they develop increase in the weakness in the immediate post-operative period, but because of the intact basal ganglia, they reacquire the original strength and the power improves in 1 to 1.5 months of time. So he started walking after 3 weeks, and this is one of the most gratifying epilepsy surgeries because the seizure freedom is almost 95 to 100%. So this is Mayu again walking, and although he continued to have some milestone problems because we cannot completely acquire those lost milestones, but he improved in his studies and now he is attending school and is completely seizure free since then, and his medications also have been reduced. So this case was special because this was an acquired pathology. For the first time I have done hemispherotomy in a post-dengue sequelae. It's a multilobar damage. Previous cranectomy was there, so challenges of operating in a previously scarred brain, and ultimately it had excellent outcome. So epilepsy surgery can be curative and can achieve this seizure freedom in selectively chosen candidates. Thank you so much.
Any questions from audience?
I hope I get my time.
I'll request Dr. Suruchi to please felicitate Dr. Abhijit.
बोलो 2 मिनट. Okay.
So, last but not at all least, Dr. Nayantara, please. You need to introduce.
Yeah, I'm so happy to see you, Nayantara. I don't think she needs an introduction. Do I have something about her? I thought it's only us, so we need to still introduce. Nayantara Das needs no introduction. She is the HOD and consultant of emergency medicine here at Manipal Hospital, Pune. She has more than 5 years of rich experience. She has completed her fellowship from Royal College of Emergency Medicine, UK. Her expertise are in accident trauma, pediatrics, emergency, medical, surgical, cardiac, neurological emergencies. She has been a member of the Society of Emergency Medicine of India, and she is an active instructor for advanced cardiac life support and advanced trauma life support. I welcome you, Dr. Nayantara. It's good to see you on stage.
Thank you so much, ma'am. And I wouldn't use a mic. I'm not very comfortable with that, but I think I'm a very loud person as it is. You may not require it. I know that I'm the only obstacle standing between all of you and the match, so I'll be quick. So wolf in sheep's clothing is my case presentation. In the ER, yeah, we see a multitude of different types of cases, but the approach is usually fairly straightforward. But every once and then we find a case that really stumps us, and this was one of them that really stumped me. So this is just the case capsule. He was a 61-year-old male. He was brought by bystanders. There was no family available. What happened is that he was riding a two-wheeler and he suddenly felt dizzy, breathless, some tightness in the abdomen, chest. He couldn't really describe what it was. So he stopped, and as he was going and sitting on the curb, he had a blackout. He had profuse sweating, he was breathless, he had upper abdominal pain, and then he vomited once. And the blackout, of course, described by the bystanders was a few seconds, that's it, after which his body tightened and then he regained consciousness. As he was entering, because he walked into the ER, the first thing he told me was that I had a CAG just 2 days ago. I was just discharged yesterday. It was normal. My angio was normal. And that's the first thing he kept saying, that this happened to me, check my heart, check my heart. So that's how he walked in. So I've taken him onto the bed. And of course, as we do for every patient in the ER, we asked if he has any allergies, and he said he has no allergies. So primary assessment for any patient who walks into the ER is always ABC. So his airway was patent, he was speaking to me pretty comfortably. He was, however, breathless. He was tachycardic with a respiratory rate of 35. His saturations were 86 on room air, and on auscultation he had both Krebs and bronchi diffuse. Coming to circulation, he was tachycardic. Blood pressure was okay, 140 by 100. I'm not very concerned about that. Pelfries were warm and flushed, and his pulses were equal. Rhythm on the monitor was a sinus tachycardia. I couldn't see any obvious ST changes on the monitor. Coming to his GCS, again, he was talking to me, he was fine. He had no sort of weakness on either side. However, he did have a tongue bite, consistent with what the history those bystanders gave me, that there was some kind of seizure-like activity, and his blood glucose was fairly normal. He was covered, drenched in sweat, not febrile. So as for any case, we obviously did an ECG, and he kept saying, you know, check my heart, so that's the first thing. And then we had a few changes, and we had his baseline ECG, which was normal. So this was his ECG right now. It was a sinus tachycardia. There was a clear-cut elevation in the iliac, and there were ST depressions in his inferior leads, and there were hyperacute T waves in the anterior leads, sort of looking like an early MI. And we did a blood gas, which showed a hyaline metabolic acidosis with high lactates, 8.2. And at that point, I ordered an SOB panel, which is your cardiac enzymes, etc., echo, as well as an X-ray. So at this point, I'm thinking, okay, this guy has some sort of cardiac history. He's come with an episode of breathlessness. He has Krebs. He's had a syncope. So I'm thinking this is cardiac. He has ECG changes. That's where my mind went. He's possibly having an MI, and he's in failure, heart failure. So as I did not even doubt myself at that point, so I put him in a proper position. I started him on MI support, and I gave him furosemide 40 mg. After that, his wife and son came, so I started to take a detailed history. Past history-wise, he was only hypertensive for 1 year. He was having dyspnea on exertion for a prolonged period of time, which is why he was suggested a TMT, which turned out to be positive. And after that, he underwent an angio, which was normal coronaries, and he was discharged on a single antiplatelet and a statin. Now, his wife tells me that he is allergic to egg, watermelon, shrimp, and I asked her, he clearly told me he has no allergies. And she said that he thinks he doesn't have an allergy, but every time he has any of these things, he gets a bit of diarrhea and his stomach hurts. And so he is allergic, he doesn't believe it, he continues to eat all of these things. So I said, okay, but he has not consumed anything in the last few weeks, any of these things. His ongoing medications, these were all after the after the TMT came positive. He was started on bisoprolol, he was on single antiplatelet, he was on ranolazine, he was on trimetazidine, he was on PPI, he was also taking these supplements, astaxanthin and multivitamins. Basically, he felt that since his TMT came positive, he wants to live a more, healthy life. So he started taking these antioxidants, in the hope that it will, reduce the progression of whatever he has. And he has a very significant family history of CAD. Like brothers, parents, everyone had coronary artery disease, so he was stressed about that. So this was just the events, how it went, how initially felt breathless and dizzy, blackout, and he was brought by bystanders. He doesn't recall that event, right from getting off the cycle until walking into the ER, he doesn't remember. Now what happens is, he worsens. He's restless, he has vomiting, he's flushed, and at this point I do a reassessment. He's still able to speak to me, but his breathlessness has increased. On NIV, 90%, I'm not happy. He should have settled much better. Chest, when I re-auscultated, silent, there's nothing, no breath sounds. And he becomes hypotensive. However, his pulses were still good, periphery is warm. And then I got the echo machine. This is why we need to have an echo machine constantly in the end. So that's why I got the echo machine after about 10 minutes. And I did the screening echo. And I found that his LV function was actually pretty good. He had V lines all over the chest, and his IVC was nice and collapsing. So all these are indicative that he's underfilled, not overfilled, which I was initially thinking. And there's no chance my 40 mg of Lasix would have done this to him. So I was very confused at this point. And at the same time, my SOB panel came back, and my PROPI, CKMB, NT-proBNP, D-dimer, everything is negative. So I'm stumped now because I have no idea what is going on. So as I was like, I need to do something, so I gave him some fluid, I decided for the bronchoconstriction I should start him off on nebulizations. I gave him a steroid shot. I started him on magnesium because silent chest I needed a proper bronchodilator. And of course I started off on vasopressors for the blood pressure because I didn't think I could wait for the fluids. He was becoming quite unstable at that point. And then the blood pressure is just reducing more and more. Nothing I'm doing is helping. And he had about 3 or 4 episodes of bradycardia. He was about to go into arrest at that point. Now I'm very scared. And then he just mentions to me that it itches, my lower limbs itch. And then I don't know what tube light has turned on in my head. But then I said that forget about the allergen, I need to treat this as an anaphylaxis, that's all I've got at this point. So I did our usual anaphylaxis treatment. I gave him an IM adrenaline shot of 0.5, I gave him a steroid, I gave him antihistamines, ATRON blockers, I gave him fluids, I just gave him a lot of fluid, and I started him on adrenaline infusion along with the noradrenaline infusion, and I literally just crossed my fingers and prayed that he responds. And magically, within I think 15 minutes, he was less breathless, his breath sounds improved, I could wean him off, and noradrenaline was tapered and stopped, and I continued the adrenaline infusion obviously for the anaphylaxis. So ultimately it turned out to be an anaphylactic shock. Now, just looking back, when I had a moment to think back on what I could have done better or where I missed something, I realized a few things. One is when I first saw him, his peripheries were warm and he was flushed. And I didn't think much of it at that time, but I should have. The tongue bite confused me. Because I was like, why does he have a seizure now? That again made me a little bit confused. Coming to the ECG changes. The ECG changes are the one thing that really made me think in one direction entirely, Also him coming in saying that check my heart, it was some kind of bias in my head. Of course, the allergy symptoms, and I should have realized that, these mild GI symptoms were possibly something. And when he entered, he was telling me that he's been having some kind of loose stools for 3-4 days, but I didn't think much of it, I just ignored it. Now, this bisoprolol beta blocker, it is said, theoretically, it can blunt the normal hypotension that you're supposed to see in an anaphylaxis. It's very less likely at this dose in this particular beta blocker, but still, that's something I should have thought of. And mainly astaxanthin. I had no idea what it was. I was like, okay, but I should have thought about that. I'll come to that. Because astaxanthin is derived from shellfish. Okay, it is a pigment that gives the color, the reddish, pinkish hue that you have with, prawns and all of that. That's derived by this pigment, and they extract that and put it into these capsules as an antioxidant, which I would not have known at all. But I did all of this research, and me and the ICU team actually together, figured all of these things out, and that we realized how important it is to do all of this. And here, when he became worse, when he was hypotensive, with this kind of hypotension, peripheries warm, it should have clicked. It did not, but it should have. And of course, a collapsing IVC in a patient with heart failure is impossible. So looking back, I could think of all of these things. However, very lucky. Studies say that the time from onset of anaphylaxis to cardiac arrest in patients who do die is less than 30 minutes. So whatever happened, however late, at least I was on time. So I do pat myself on the back for that. So the World Allergy Organization defines anaphylaxis with 2 criteria. One is that, and it's interesting, the involvement of skin and mucous membranes is mandatory for you to say, okay, this is anaphylaxis. And in his case, he didn't have that initially. There was no reason for me to suspect it at that time. However, there's a second criterion, which says acute onset of hypotension, bronchospasm, or laryngeal involvement, even in the absence of mucosal changes, which is something that we usually overlook because we say that if there's no rash, how can it be anaphylaxis? Usually. So this particular entity was another thing, Kunis syndrome, which is basically allergic MI. So that's something again that we need to consider because the inflammatory markers that are released by your mast cells or histamine, etc., they do 2 things. One is it acts directly on the heart and causes myocardial ischemia, and it also causes vasodilation, profound vasodilation, both of which can cause ECG changes. And unfortunately, studies show that if it is the first one, that it has actually caused coronary vasospasm directly, in that case, the patient needs to go for an angio and possibly a plasty. If there's even a small clot there, the vasospasm will cut it off. However, in this particular case, the ECG changes were likely due to the profound vasodilation in the third space loss that was happening, which is why he was having these ECG changes. So it's very important to differentiate between the two because the management completely changes. The first type will not respond to just your adrenaline and your anti-allergic medications. So to summarize, anaphylaxis is very unpredictable, varying range of signs and symptoms, and the patterns of target organ involvement may vary. For example, in his case, his shrimp allergy was only causing GI, never rash. But that doesn't mean he'll never have an anaphylaxis, and that's something that I learned that day. And a high index of suspicion in patients with unexplained hypotension or bronchospasm, have to keep it as a differential in your head. Comorbidities and concomitant medication use can blunt the response to your treatment and the symptoms, so that's something that to keep in mind. And the mean time to cardiac arrest in food-induced anaphylaxis per se is less than 30 minutes, making prompt retribution very essential. And last but not the least, you cannot get anywhere without a detailed history. So history, there's nothing more important than taking a history. The farther backward you can look, the farther forward you're likely to see. Thank you.
Wonderful case presentation. Now I also wanted to ask, he also took azithromycin, which is also a cause for intercoronary inflammation at times. So that is also like missed. That was a very important history that he was put on macrolides for just 1 week ago. Angiography was also done 1 week ago, which was normal, but it could have been just normal at that point of time. So that history was also very important, that the patient had taken azithromycin in the past 1 week and came with that. When you said xantho, whatever that drug, I said I think that is the one which is the culprit. I was going to say, but then you came to that point. Very nice case, Manipal. Very nice.
I would request both of you please felicitate. That's a special case.
Yeah.
Now I request Dr. Junaid Patel to felicitate Dr. Rahul Chaudhary. I'll request Dr. Digambar Sarje to felicitate Dr. Suruchi Mandrekar. Moving towards the end of the session, I'll request Dr. Chinmay Eram, Head of Medical Services, to conclude the session.
As we conclude Manipal Med Connect 2025, it is my privilege to extend our heartfelt gratitude. A sincere thanks to our distinguished speakers and panelists for their invaluable time, insights across a wide range of medical advancements. Your expertise has made this conference a truly enriching experience. I also want to express my appreciation to our esteemed dignitaries, Dr. Maya Bhalera, Dr. Sarika Lodkar ma'am, Dr. Govardhan Ingre, Dr. Dilip Kamath for their presence and support. Special thanks to our keynote speaker, Dr. Vijay Kumar Dogre, for an inspiring address. A big thank to the organizing team here at Manipal Hospitals, Bane, starting with our Cluster Director Anand Mote sir and Organizing Secretary Dr. Prasad Deore sir, and IMA-PCB for their dedication in organizing this event. To everyone who attended the event and gained insights, and lastly, gratitude to the support staff and volunteers who worked tirelessly behind the scenes to make it a success. Thank you everyone and have a great evening.
Extend some good luck for the match also.
And good luck to India for tonight.
77 for Pakistan.
Pakistan
77 for
77 for 2.
77 for 2. Over 19.
या इकडे साईडला त्यांना काय म्हणताय
त्यांना इन्व्हाइट करा सगळ्यांनी
ते मॅडम जवळ जाऊन
Hello. Before concluding the session, may I request our cluster director to please be on the dais for 2 minutes only. I have to felicitate some people. I request Anand sir to felicitate our head medical services, Dr. Chinmay Ram. तोच स्वतः मोमेंट घेऊन येतोय. Please. Sir, please. Thank you. Thank you, sir. May I request Dr. Riya to be on the stage? And I request Anand sir to felicitate Dr. Riya. She had taken a lot of efforts and thank you very much.
Thank you very much.
Thank you. Thank you. May I request Deepak Patil, heading sales team. Thank you, Deepak. He had done a lot of efforts. आणि अटेंडन्स जशी कमी व्हायला लागली तसं सगळ्यात पडलेला चेहरा यांचा होता. वी शुड ॲप्रिशिएट यू. Don't blank. May I request Dr. Surbhi and Dr. Supnali? They should be felicitated. त्यांचे मोमेंट तेच घेऊन येतील. I will bring it. तुम्हाला करून देतो. Just take that. They both have really taken the efforts by completing all the MMC accreditations, forms, certification, logistics. Thank you, thank you.
I now request
Dr. Swapnali, please. She had also taken a lot of efforts. And now the session is over.
No, wait. I request Anand sir to felicitate Dr. Prasad Dwivedi sir, organizing secretary. I request Sadika ma'am and Amit sir to please come on stage and felicitate Anand sir also.
Thank you. Now group photo, please group photo.
Okay.
Sir?
Close.
This is group.
Suruchi, Nayantara, Rahul, Deepak,
Yes.
Prasad, Jagdish.
ये अपनी वीडियो
Abhijit. Prakash. एक दोन चेअर द्या ना. एक दोन तीन चेअर द्या, बसायला होईल. तीन चार चेअर देऊन टाका. तिथं बसायला आहे, जागा एवढं बसतील का गुरु? दे ना 2-3 चेअर. त्यांना सांगा तसं. ग्रुप व्यवस्थित आहे. नको म्हणतात का? समोर रेडी? समोर
अरे आहे सर काय घ्या घ्या.
एक फोटो घेऊ द्या.
इथे आता
थोडं पुढे या तुम्ही. इकडे पुढे या, पुढे.
ते मागचे येत नाहीये.
ओके, लुक हियर, स्माइल.
थँक यू.
श्रीनिवास समिती कॉन्टॅक्ट करा, होऊन जाईल तुमचं. नाही दादा, घ्यायच्या आधीच. चल ना, पॅकअप कर मग, उठ घेता. झालंय ना? नाही दादा, घेतला. थँक्यू. उठ घेता, कर ना. कोणाला?
कॉफी घेणार? चिन्मय
बंद करा, तिकडून बंद करा हो साहेब. तिथून बंद करा. तो फोन
सेशन चालू करायचं.
Thank you so much. Kal aa rahi ho?
इसका